Chowda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Ask series, which is organized by AGOG, that is Academia of Global Obstetrics and Gynecology on Shield Connect platform. So, in this task series, we will be covering the topic from A to Z topics, and today the episode is F, which will be covering the topic fetus as patient. So before we start with the series, let me show the short introductory video for AGOG. And with that, let us start this wonderful episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
So now I'm happy to introduce the master of ceremony for today's episode, Dr. Anusha Devalia ma'am and Dr. Shruti Thar. So let me introduce Dr. Anusha Devala. Ma'am is Assistant Professor of People's College of Medical Science from Bhopal. Ma'am is also Consultant Obstetrician and Gynecologist, member of FOXY PCOS Society, contributed to chapters in 4 books, published articles in national and international PubMed Index journals, active reviewer for PubMed Index journals, awarded with Best Paper Prize at West Zone UA FOXY, third prize for poster in FOXY cervical cancer, and update at 2021, second prize in physiology quiz competition, and presented numerous papers and posters at regional and international conferences. And ma'am is a university rank holder in all MBBS subjects with gold medal. And now let me introduce Dr. Shruti Thar. Ma'am is Medical Director at Thar Women's Hospital, Consultant Obstetrician and Gynecologist at Puja Nursing Home in Mulund, Fortis Hospital in Mulund, and Hira Mongi Hospital at Mulund. Ma'am has won MOGS Best Youth Council Member Award in 2021-2022. Special interest is high risk pregnancy, PCOS, endoscopy, and menopause. Ma'am is active MOGS Youth Council member. So with that, I will hand over this session to Dr. Shruti Thar ma'am. Thank you so much.
Thank you, thank you. I welcome all the delegates and all the speakers for this wonderful ACOG task, which is Trending A to Z series. And today I've been fortunate enough to be hosting the series F, Fetus as a Patient. So without much ado, let me begin by introducing Dr. Komal Chavan. She's a medical director at Chavan Maternity and Nursing Home. She's a senior consultant and DNB teacher at VN Desai Hospital. She's a zonal coordinator FOXY for the current year. She's also a chairman EMOX Family Welfare and MTP Committee 22-24. She's a member managing council MOGS. She's won various awards, with recent being N.A. Pandit and Shailaja Pandit Women Empowerment Award 2022, Dhira Award 22, and a FOXY Dr. Meru Dara Hansotia Best Committee Prize 21. Welcome, madam. I would also introduce Dr. Niranjan Chavan. He's the president of MOGS current, joint treasurer FOXY 21-24. He's a professor and unit head at Sion Hospital. He's a member oncology committee Suffolk 21-23. He's also joint secretary AFG 22-23. He's been a dean AGOG and chief content director at High Grade and FEMAS courses. He's editor-in-chief at FEMAS, JGOG and TOA journal. He's got various publications in international and national journals. He's a national coordinator of FOXY Medical Disorders in Pregnancy Committee, and he's the chair and convener of FOXY Cell Violence Against Doctor. Welcome, sir. I would request Dr. Komal Chavan, ma'am. to introduce our chief guest and guest of honor.
Thank you. Thank you so much, Shruti and Anusha.
Thank you.
Wonderful coordinators I have for today. And I welcome you all for this trending Ask the Expert series. And today is episode F, and F is for fetus, and we devote it to the fetus. Without any, I just want to make a disclaimer that I'm not going with the term fetus as a patient or any fetal rights or any medical legal, but as an obstetrician, we have patients who are our pregnant mothers, and we sometimes need to think on the aspects of fetal. And this is totally a medical aspect of fetus, which we are going to tackle, and that is the idea behind this webinar. And we have all the eminent speakers who have come today, Dr. Sita Pal, Dr. Chinmay Ratha, Dr. Bela, who will be moderating, and the esteemed, the whole array of the fetal medicine specialists who are there in the panel. And the most wonderful and the gorgeous chairpersons I have, Dr. Selvapriya, Dr. Pranjal Sharma, Dr. Sasmita, and Dr. Poonam Lomba, and all of you who are present here today at the inauguration. I welcome you all. And we are really happy and fortunate to have Dr. Pardesi sir, Dr. Rajendra Pardesi, who is the current president of AMOX, as a chief guest today. And he has also have a very keen interest in ultrasound. I remember the conferences, Sonocon and all, which he has organized. They were really much sought for, and everybody was really registering. The scientific content of the conference was so enriched. So I have an expert who is in a expert in ultrasound and fetal medicine. So I welcome Dr. Pardesi sir. Pardesi sir being the AMOX president currently. He was also the first vice president of AMOX earlier, and also the vice president of Foxy in the year 2019-20, where I happened to be the chairperson, and I had the fortunate with working with him very closely. He has been faculty at various international and national conferences, be it Taipei, Bangkok, Kuala Lumpur, Rome, and also had been earlier the chairperson of Food and Drug Committee of Foxy, where he also won the Mehrudara Hansotia Best Committee Prize. So over to you, Dr. Pardesi sir, and I request you to address all our audience. Thank you.
Good afternoon. Good afternoon, everybody. Thank you, Dr. Komal, for your kind words and introduction. But I would like to add in my biodata that I am disciple of Dr. P.K. Shah when I was in Sion since 1987. He's my mentor. Proudly say, I can say, I learned all these things from Dr. P.K. Shah only. So respected Dr. Gitendra Sharma, Dr. Bela Bhatt, Dr. Chinmay, Dr. Sita Pal, and Dr. Komal Chavan, Dr. Niranjan Chavan, and Dr. Pranjal Sharma. Pranjal Sharma is our ever-active chairperson of AMOX. I wish to congratulate Dr. Komal Chavan and Dr. Niranjan for organizing such a nice webinar on sonography on fetal aneuploidy screening, multiple pregnancies, and FGR. Dr. P.K. Shah is expert, and FGR is his topic of interest, and he is expertise in that. So nowadays, fetal medicine is really a growing branch, and we should also learn, each and every obstetrician should learn fetal medicine and ultrasound. With the galaxy of speakers like Sita Pal, Chinmay Rath, Dr. Bela Bhatt, and chairperson Dr. Selvi Priya, and all others like Dr. Poonam Lomba, Pooja Loda, Pragya Mishra, Shaswat Das, Sasmita Das. I think this will be going to be a nice webinar. It's academic and practical webinar. I wish every success to this webinar. I wish every success to Dr. Komal Chavan for our future endeavoring in Foxy. Thank you. Thank you so much for inviting me. Thank you. Thank you.
Thank you. Thank you so much, Pardesi sir. And we all are students of Dr. P.K. Shah sir. And I can proudly say that, and I am blessed to be one of the students of Dr. P.K. Shah. I think Dr. Sita is also from science. So we all have a science connection. And Bela being in Imaging Science Committee, I think we all have a close association with Dr. Shah sir, and he is very much part of this webinar, and he'll be joining soon. He's already joined, but he is little held up, so he will be there as an expert for the panel and sharing his views. So we are fortunate to have Dr. P.K. Shah sir also joining soon. And now I welcome our guest of honor, Dr. Geetendra Sharma. Dr. Geetendra Sharma, we all know that he is currently the vice president of FOXY, and he is a practicing obstetrics and gynecology from city of Ahmedabad for last 28 years. But I know that his immense interest is in medical legal, and he has been the medical legal counselor. He's also done law with a lot of gold medals and accolades. He's author of books related to law in obstetrics and gynec, consent in OBGYN, law a doctor must know. So I think being the chairperson of Ethics and Medical Legal Committee of FOXY, he has guided many FOXians in the field of law in medical legal problems, and that is really commendable. And I welcome Dr. Geetendra Sharma sir, and I request you to kindly address the audience.
Good evening, everybody, and thank you for inviting me and giving me the opportunity to be the guest of honor for this webinar. I know that Dr. Komal is having very much good potential to organize such webinars, and I have attended many conferences and webinar organized by Dr. Komal. I wish her a great success and a great future ahead in FOXY. I know that today's webinar having good speaker like Dr. Bela, Dr. Sita, Dr. Chinmay Rath, and Dr. Pooja, and many more. So it is going to be a great success. So by not wasting much of your time, I wish you best of luck, and I wish that this webinar will be a great success. Thank you once again for inviting me as a guest of honor. Thank you, madam.
Thank you so much, Dr. Geetendra sir, and we are honored by presence of our esteemed chief guest and guest of honor. And now we go ahead with the scientific content, and I hand over to the coordinators to introduce our chairpersons and go with the scientific.
Thank you, ma'am. Thank you. So let's begin with our first session. Let me begin by introducing our chairperson for the session 1, Dr. Selva Priya Saravanan. She is a OBGYN and fertility and fetal medicine specialist. She is a director at Spring Fertility Fetocare Fetogene in Tamil Nadu. She is also clinical director, Department of Reproductive and Fetal Medicine, Dr. Jayasekaran Medical Trust Hospital, Tamil Nadu. She is secretary IFS South, Tamil Nadu. She is also vice president at Nagarcoil OBGYN Society, chairperson at Tamil Nadu FOG, and coordinator of FOXY South Zone. She is a recipient of multiple awards, the latest being IMA President's Appreciation Award 2022, Dhira Award FOXY 22, and a Best Fertility Center Award 2023. Welcome, madam.
Thank you so much, dear. That was long.
I'll welcome our second chairperson, Dr. Pranjal Sharma. She is a director, Sharma Hospital, Amravati, director, RIMS Amravati, zonal coordinator, MOX 2018 to 22. She is a chairperson of website and publication committee, MOX, currently 22 to 24. She's also been an organizing chairperson for Adolescon 2020. She's also a recipient of multiple awards, the latest being the champion of FOXY Award V for Stree Puraskar 2022 and Best Zonal Coordinator Award 2022. Welcome, madam. I would request Dr. Selvapriya to introduce our first speaker.
Thank you so much. At the outset, congratulations, Komal and the entire team for pulling up a show. F for fetus as a patient, and yes, it has a voice, and we are going to elaborate it in the detail. And is to introduce our Sita Paul madam. And I've heard madam speaking in a couple of conferences. There is so much clarity in her thoughts, and listening to a basic topic like this from her would be really enlightening. And as we all know, she's the chairperson of Genetics and Fetal Medicine Committee of FOXY for 23 to 25. And she's the clinical secretary of Bengal OBG Society and Honorable Vice President of Society of Fetal Medicine, Kolkata chapter. and Clinical Secretary of ISOPOP Kolkata chapter. And she's an examiner for MRCOG Part 3 and Faculty MRCOG Part 2 and 3 courses, and member of Neonatal Board Specialist Committee, Maternal and Fetal Medicine. And Sitapal Madam, more than anything, she's very well known for her oratory skills. And I'm sure that this aneuploidy screening, she's going to throw a lot of light and clarity. And this will be something which will be definitely take home for us. And over to you, madam. And we are eagerly waiting for your aneuploidy screening.
Thank you, Sarvapriya, for that kind introduction. And at the outset of thanks to Komal for involving me in this beautiful A to Z series, trending series, very innovative idea. And it's really nice to connect with Cyanide. So greetings to Pardesi sir and PK Shah sir for being our teachers and mentors, without whom we've not come, we would have not been here so far in our lives and career. So thank you for that. So I'll just share my screen and we're going to be talking about, fetal aneuploidy screening. Is my screen visible?
Yes. Yes, ma'am.
Yeah. So thank you once again, and that's me for you. So when we talk about aneuploidy, when we talk about chromosomal abnormalities, it could be either abnormalities of number, which is basically the aneuploidies, where there's an extra chromosome 21, that is trisomy, which is the most common. It could be triploidy or tetraploidy, where the entire set of chromosomes is triple or quadrupled. Or it could be abnormalities of structure, where there's a balanced translocation, or unbalanced, where there are some deletions or duplications of small areas of chromosome. Or they could be mosaic patterns with different cell lines, where the phenotype may not be badly affected. So here we are talking about aneuploidies, which is basically abnormalities of number. Now, the reason we do any aneuploidy screening is basically that we know as a routine, because a lot of these aneuploidies can occur to women at lower age, and it is, they could be high-risk conditions as well, but routinely to screen all the entire population. Or it could be there is a possible heritable condition, previous affected babies, or in the family there is a problem. Advanced age, which is one of, we can consider it nowadays, but that becomes a routine as well. As part of recurrent pregnancy loss, is a positive family history, a consanguineous marriage, or just an anxious couple. Now, when we screen for aneuploidy, it is important to remember that the risk of fetal aneuploidy reduces with gestational age. So when we start screening, when we do the screening, and why we have timed the screening around the first trimester, that is between the 12th week, is 30% of the affected fetuses die between the 12th and the 40th week of pregnancy. So which means that if a woman, she's like a woman who's 35 years old, if the risk for trisomy at the 12th week is 1 in 250, when she reaches 40 weeks, the risk is reduced to 1 in 350. So a woman, if she comes at around 20 weeks or something, and if she has missed her screening, and you say, oh my gosh, she has missed her screening, there's nothing to be alarmed about, because she's already reached 20 weeks, and the risk of trisomy has decreased. So we can be slightly reassured in that respect, but of course, the aim is to catch them earlier. So with trisomy 21 especially, there's a 40% reduction from 12 weeks to term and 30% reduction from 16 weeks to term. So that sometimes becomes a sort of a reassuring factor if we don't have had any screening. Now, why we look at trisomy 21? Because it is the most common cause of intellectual disability and accounts for about 15 to 30% of cases, where in India, the prevalence is reported to vary from anywhere between 1 in 1230 to around 1 in 1400. And it does increases with age, and I said earlier, as decreases with gestational age. But the most important thing to remember is trisomy 21 and the other aneuploidies, 70% of the babies are born to women below 35 years of age, and that is why we try to make it we are offering as a routine screening, and trisomy 21 still remains the main focus of screening, because the other aneuploidies are more or less detectable on ultrasound. So efficacy of aneuploidy screening, especially Down syndrome or trisomy 21, has revolutionized over the period of 50 years. And all these attempts are there because we want a test which has a higher sensitivity and a lower false positive rate, which means that the test should be able to detect, I'll come to that, with a lower false positive rate. So all the tests that have been evaluated so far, they all used a fixed false positive rate of 5%. So what does all this mean? Basically, that if in your screening population, the sensitivity means that the ability of the test to detect all those with the disease in that screen population, and specificity is those without the disease. And here, when we are talking about false positive, it means that the number of individuals who are without the disease, but they have a positive screening test. So that is what we are trying to reduce that number by increasing the sensitivity of the test by adding different parameters, as we will see, so that the number of unnecessary interventions that might be required for a positive screening test is reduced. So when we talk about screening and the different markers that we use and the values that are listed in our report, we need to know basic terminologies. So quickly going through those, one is the median. So median, as we know in statistics, is the middle, value of a set of numbers. And we talk about multiple of medians. It is basically the observed value divided by the median value for normal pregnancies at the same gestational age. So if you have a free beta HCG of 80 for that patient, and a median free beta HCG at that gestational age is 40, so the patient's mom is 2. So considering a value of 1, anything plus or minus 2 standard deviations would be considered as abnormal. So that would be around 0.5 to 2, up to that would be normal. Anything less or more than that would be abnormal. Now, when a patient enters your clinic, she always carries a bag of risk with her, and that is called the a priori risk. So every woman has a risk, and that depends on her age, gestation, when she walks in, or if she's an IVF pregnancy. That's why we need to know her correct date of birth or the age of donor. And then we look at a likelihood ratio. That is when we add all these markers, and then we look at the scan or we look at the biochemical screening reports we have a likelihood ratio. So every time a test is carried out, the a priori risk is multiplied by the likelihood ratio of the test we perform to calculate a new risk, which then becomes the a priori risk for the next test. So if you're doing a series of tests, which shouldn't be ideally the case, but you must remember what a priori risk you have started off with. So what is the likelihood ratio? That is whatever we find, whatever marker we find or a value we find, we calculate the probability of the marker being present in the fetuses with trisomy 21 or any particular aneuploidy. So each mom value has a likelihood ratio. So the maternal age probability is 1 in 1,000, and then you have a particular marker where the likelihood ratio is 1 in 10. The new probability will be 1 in 100. So this is how we calculated the likelihood ratio. And another important factor to remember is the positive predictive value, which means the odds of being affected with a positive result, which means if a patient enters your chamber, she wants to know what is the risk of my baby having this problem. So that is that subjects with a positive screening test truly have the disease. And that is a ratio of true positives to false positives. This means that if there is an OAPR of 1:5, one will have an affected pregnancy for every 5 that do not. So this is another important concept that we have to be aware of. Now, coming back to what we have evolved, initially it used to be age-related, where I used to be karyotyping all those women who were above 35. Then came the triple screening, and then the rapid aneuploidy detection. And then the major landmark was the combined test. And then now we have the new, well, not so new, the kid on the block, that is the NIPS, which will offer more sensitivity. So the first thing that came up was the nuchal translucency, which is basically the sonographic appearance of subcutaneous accumulation of fluid. And they found that considering the Downs babies have an increased nuchal thickness, they found that if this thickness was higher, the risk of the baby being chromosomally abnormal or basically having aneuploidy is higher. And obviously, a very important factor to remember that this is gestational age dependent. And if the NT is more than the 95th centile for that gestational age, obviously a direct testing is preferred. What about the additional first trimester markers on ultrasound? That is, you assess the nasal bone, ductus venosus flow pattern, tricuspid valve. All these can improve your detection rate to 96% by lowering the false positive rate to about 2.5%. Now, if you use these markers, ultrasound markers, and you combine the biochemical markers, what other screening options do we have? So in the first trimester, we have a double marker, that is the PAPE beta HCG. When you combine with the ultrasound markers, you have the combined test where you include the nuchal translucency, PAPE and beta HCG, which becomes your standard combined first trimester test. And then if you add these other markers, especially nasal bone, you're increasing your sensitivity. If you add other biomarkers like the alpha fetoprotein or PLGF, that becomes the enhanced FTS, which can give you information about other things like neural tube defects or preeclampsia, which enhances the quality of the FTS. If you've missed the boat in the first trimester, you have the second trimester, which is the quadruple test, which is an equally good test, especially if the patient has missed it, but it is less effective, as we will see in the further slides, and of course, NIPS. And then you have different models where you use these tests in different combinations, like this, that is purely the combined, either do a sequential, contingent, or integrated, which will again explain. But the important thing to note is that test with at least 70% detection rate for a 5% false positive rate should be used, which means that all these tests are able to sensitivity of more than 70%, they have a detection rate of more than 70%, and the triple test does not fall into this category. So the triple test should not be considered and should not be used in routine screening. Now, when you use these serum markers, it is important to know that certain things in the pregnancy can affect these markers, and that is why they become abnormal. So like the beta HCG increases in Downs, whereas the PAP is reduced in Downs and FGR. Inhibin A increases in Downs when you use as in quadruple. The PLGF decreases in FGR. The alpha fetoprotein increases in open neural tube defects in FGR, whereas the urinary estriol decreases in aneuploidy. So all these are calculated as MOMs, which I said earlier, and one abnormal variable can obviously make the screen positive. So you have to look at the report to decide what has made the screen positive or not. So as I said, what are the types of screening offered? The one is the integrated, where you combine the biochemical and the ultrasound of the first trimester with the biochemical markers in the second trimester to generate a risk of 1 in 250, which is usually taken as the cutoff. So here what happens is you have to wait for the entire second trimester to get a result. Here, sequential screening is stepwise as integrated, but the disclosure of the first trimester screen is given to the patient, and then you get a full result after you integrate the sequential test in the second trimester. Whereas what we more commonly use is the contingent, where depending on the first trimester combined result, we divide the results into either screen negative, intermediate risk, or screen positive. Now, as I said, these are the different models that we use. We can use age, which is no longer recommended. Ideally, just the CRL and NIPT should not, it can be used, but you have to make use that you have to remember that the certain disadvantage of you using purely NIPT as a screening test. It's ideally for trisomy 21 in the first trimester, but you have to have it misses the advantages of a trisomy for first trimester scan. If you include age, CRL, and NT, of course, it is skill dependent. If you only use biochemistry, the detection rate becomes poor. So the combined risk, where you use the age, maternal factors, the crown dump length, PAP, beta HCG, that becomes the test for everybody with a good sensitivity. If you add other markers, that obviously increases, and then you have your T1 combined test plus T2 quadruple, T1 quadruple, or T1 penta, where you add the other markers, as I said earlier. So these are the efficacy of different screening tests, and one that we use is the combined test, which is a good sense detection rate of 85 to 95%. But when you combine the other markers, it can increase to 93 to 96% for a 2.5% false positive rate. Now, this is the efficacy, again, showing you each of it. That is the age plus combined test, which is 86 to 90%, quadruple test of a good 75 to 80% if we have missed the boat. Now, this is what the report will look like. I'll not go into the details. Now, what is cell-free fetal DNA, which is the new, which is the additional thing that has come up and has really become the screening of first choice in terms of using, especially for trisomy 21, which is basically, it is the DNA of fetal or placental origin, but it is a cell-free DNA which is found circulating in the maternal blood. Now, it is important to know that it is not exactly an evaluation of the fetal blood. It is only a comparison of the maternal DNA with a normal of a sample. And if the DNA is found to be higher, it is assumed to be that of an abnormal fetus, and that is how we come to a conclusion. It does not exactly calculate the fetal DNA. So it is done by collecting the maternal blood anytime after 12 weeks, and it is useful for screening the common trisomies. And of course, it can be used for other things like Rh negative and fetal sex determination. Now, this is what I was saying, that you use the DNA for analysis, and it is important to remember that the fetal fraction that is there, it should be about 4%, and there are different methods of doing this analysis, like the massive parallel sequencing or single nucleotide polymorphism, and it basically measures the ratio of chromosome 21 signals versus the control chromosomes. It compares the signals, and anything extra is assumed to be arriving from the aneuploid fetus. So when you add this in your basket of tests, and it shows that the detection rate, especially for trisomy 21, is very, very good in terms of 99.7%. It's not 100% because it's still a screening test for a very, very low false positive rate. But that's why it is important to counsel the patient before we do any of these tests, that especially the NIPS, that this is only a screening test. And as of now, it is best validated for trisomies, the common trisomies, and information on microdeletion syndromes does not have robust, only that the recent one shows that we can use it for 22q deletion, that is the DJOT syndrome. And because it is a screening test, any positive test must be followed by direct invasive test. So any decision for TOP termination should not be based solely on these NIPT results, and it does not give you added information on other conditions. So why there can be false positives? Because if there is a demised twin, vanishing twin, if there is maternal obesity, which reduces the fetal fraction, or there's a maternal cancer, all these things, or confined placental mosaicism, all these things can cause false positive, and that is why it is important to remember to do an invasive if it comes positive. In our setup, we don't use it as a primary screening, though in the West, it is very common to use that as a primary screening method with a first trimester scan. In our country, we use it as a secondary screening method when there is a high risk on conventional or intermediate risk on conventional screening. Of course, but if there's a history of prior 21, or ideally you should be doing an invasive, but some women may want to opt it directly if they are, older age, or if they don't want to go in, they want a better test for trisomy 21. So when you add this to your markers, as I said, the efficiency increases to almost more than 99%, but it is not 100%. In our own country, we've had this study where, Professor Suresh has seen the Down syndrome screening with additional serum markers, and they have said that if you add PLGF, AFP in your first trimester, your detection rate increases to 90%. And if you just do the biomarkers, you get a good detection rate of 80% without using the NT. So even just using serum markers has a good detection rate. Again, important to remember that when you do the first trimester screening, certain factors influence these, like in diabetes mellitus, the PAPA is reduced. That would increase your false positives. In IVF, the PAPA is lower. Vanishing twin or fetal reduction, especially if it's done, ideally you should not be doing the first trimester biochemistry. But early pregnancy bleeding, there should not be any problem. So you can go ahead with your routine first trimester screening. So this is what the Fetal Medicine Foundation has evaluated, that this is for cell-free DNA, that is, if you do a cell-free DNA and the result is negative, you can go back to ultrasound, but if it is positive, you can do an invasive test. And if you do a first trimester combined screening, you divide it, that is a contingent screening, where that you divide it onto a low risk, intermediate risk, or high risk. Now the cutoffs varied with different centers. In our usually the common used cutoff is 1 in 250 to 1 in 1000, which becomes the intermediate risk. Anything more than 1 in 250 becomes a high risk, and anything less than 1000 becomes a low risk. So if it's a high risk, we would recommend an invasive test. And if it's intermediate, depending on what causes I would add an addendum here, depending on what causes the intermediate risk, if any ultrasound variables are high, then maybe you would offer an invasive test. But generally, if the ultrasound is normal, you could advise a cell-free DNA, and depending on that, if it's positive or negative, take it accordingly. In multiple pregnancy, you must remember it all depends on the chorionicity, because in monochorionic, it is a single probability for the whole pregnancy, whereas in dichorionic, it is fetus-specific probability. And all the tests that we spoke about perform equally well, but the biochemical risk is usually a pseudo risk because of the chorionicity, and that's why the combined screening sometimes becomes less effective. And when you use the combined test, has a good detection rate of 86% for 5% for dichorionic and around 87% for monochorionic. And even the NIPS actually performs very well. Again, monozygotic pregnancies, in fact, it is some studies have shown it has better sensitivity. Dizygotic pregnancies, individual fractions may differ, so you may have a false negative. Again, important to remember that test failures can occur at approximately 5%. And very, very important that if it is screen positive, we don't know which baby has given the test as positive. And that's why you have to do a double amnio to confirm which baby is actually affected. Having said all this, it is vital to say that you have to have a mandatory first trimester scan because you have look at so many other things. You look at structural fetal problems because if there is a structural problem like a megacystis or a diaphragmatic hernia staring at you, then you don't want to go through these tests at all in the first place. You would directly go in for an invasive. And of course, you could add by adding other markers, you can like the uterine artery PI and the PLGF, you can screen for PT, you can screen for FGR, and also assess whether this lady needs any assessment for cervical length later on. When you come to second trimester, there are some markers which have some significance, which were put as soft markers, and different markers were found, which were found to be at increased incidence of in trisomy 21 babies especially. So each marker has had a likelihood ratio, and the most important ones are the absent or hypoplastic nasal bone, the ARSA, and ventriculomegaly, of course. But individually, if you find ventriculomegaly, you should be advising a invasive test, whereas if there is an absent or hypoplastic nasal bone isolated, there is a sort of a different view coming up that if everything else is normal, it depends on whether you have to counsel that it may ultimately be normal as well. So you put all these markers in the second trimester assessment. You can go onto the website and just put these markers, and then you will get an additional risk in the second trimester, depending on what the first trimester risk was, and then decide whether the risk is increased depending on the presence or absence of these markers. So in India, this is the scenario where you do a first trimester screening with a double marker. And if the high risk is more than 1 in 100, 1 in 101 to 100 in 1,000, this is obviously including the other markers, or if it's less than 1,000. And depending on that, if it's intermediate, you can either offer an IPS or you can do a quadruple test where you integrate. And it's important to remember that you do it from the same lab so that you get the same test that is validated from the lab. Or you can do a genetic sonogram to decide whether this needs any further testing or not. This is another protocol that we said that, that the same thing as I was repeating, that in the first trimester, depending on low risk or high risk, you can combine and then decide whether she needs any further testing. Now, an important again thing to remember is that there's a positive screening test. Definitely do not terminate the pregnancy just on the basis of positive screening. It is important to find out why the test has come positive, counsel the patient, and decide accordingly what needs to be done. So if you're using quadruple test as a secondary test, use the final risk of FTS as a priori, which I said that what the previous test has shown you, that would be your background risk to start off with. You integrate the test from the same lab. And obviously, when you integrate it, the sensitivity slightly reduces. And that's why it is better to avoid two biochemistries. When you talk about prenatal diagnosis, we have colonic villus sampling in the first trimester or the amniocentesis after 15 weeks. And whatever test you send it for, it is important that along with FISH or QF-PCR, now the advice is to send for chromosomal microarray because you might be missing out on deletions and duplications, which also might have a problem. So these are the different tests. Just putting up on that you have the QF-PCR where it comes in about 2 to 3 days. Karyotype, definitely, and chromosomal microarray, which have the different different times of turnaround times, and that is why it is important to screen them early and give enough time for counseling. And based on these tests, whether we need to do or not. But the other tests would be, depending on what we find on the chromosomal microarray, we wouldn't need to do these advanced tests for all patients. This is a microarray which looks at more detailed of the more resolution of the chromosomes. So it identifies all abnormalities, but obviously it cannot identify all genetic disorders. So if there is a fetus, there is an abnormality, and you're doing an invasive test, it is always better to do a chromosomal microarray because it gives you additional 6 to 15% of yield depending on what you want, on what problems are there. So the recommended ACOG practice bulletin for these is that CMA should be made available to any patient undergoing invasive, and if specific aneuploidy detected, then you do KT plus FISH also before the CMA. And testing for chromosome 21 is not enough because we need to look at other problems also which may be there in the fetus. So the take-home message for today will be that all women should be offered prenatal screening. First trimester gives us a huge window of opportunity, but it is important to adequately counsel the patient as to what she's going in for, what can be expected of the result, especially from NIPS, or even if you're sending a chromosomal microarray, whether there could be variants of unknown significance. All these have to be tested, counseled before and even after the test. And the test offered will depend upon the gestational age, your resources availability, the affordability of the patient, and the operator expertise. In low risk, we tend to offer the combined FTS, especially if she's come in the first trimester. Anything more than 1 in high risk or a structural anomaly, we would offer an invasive testing. Important to remember that cfDNA, that the cell-free DNA or NIPS remains the most promising screening test, but it is limited to the common trisomies and cannot replace the diagnostic test, which is, again, individualize every patient because no single combination of markers is appropriate for all situations. Thank you for your patient hearing. Thank you.
Sita, madam, so that was A to Z cover-up of complete aneuploidy screening. I'm sure anybody who's listened to this topic, they would be having all the complete knowledge about the things. And special attention was given to the multifetal gestation also. And as you said, the vanishing twins definitely affect a lot of the practice today with screening because of this IVF practice which is going on, and we're having the multifetal gestation. That's rightly said. And thank you so much for elaborating on each and every aspect, including the recent likelihood ratios and everything. Is there anything, Komal, Chinmay, anybody wants to add up?
Yeah, anybody wants to add? Thank you.
No, I think excellent, summary of aneuploidy. The screening is just not, it's not possible to complete everything in screening in one go.
Yeah, I think I overshot as well. I'm sorry if I've overshot the time, but yes.
No, it was fun. I was listening to everything and you kind of answered a lot of questions for us in the next session also. So thanks.
Thank you. Thank you so much. Thank you.
All the screening strategies has been well compiled, Dr. Sita. Congratulations.
Thank you. Thank you so much.
It was really very a synopsis of what actually we should do. You know, there are so many dilemmas which come into our mind when we come patients with coming with some test positive, and those dilemmas also you have solved. So I think you have covered very beautifully, Sita. Thank you so much.
But how much ever we try saying that the triple test obsolete everywhere, wherever a fetal medicine person is there, how much ever we scream, we don't stop seeing the triple screening test reports. I think we all should stand and ban these labs from doing triple tests.
Absolutely, that's what I tell the labs. Unless
some labs have withdrawn.
Yeah,
some labs have withdrawn. But there are others who cite the obstetrician and saying.
As fetal medicine committee chairperson, you should issue a notice only. We will not are forced to do unnecessary.
Point noted. Yeah, absolutely. It should be banned. It shouldn't be offered in the first place by the labs. Exactly. When a patient goes, they should say we don't do it. You know, that's the only way.
You should do that. The fetal committee of Fox does not approve the triple test being done, and the decisions based on the triple test intervention. Something like that. Anyways.
Having said that, we have seen a lot has been reduced. We see a lot less coming nowadays. I think the message is going across, but it's not fully there yet.
And that is also mainly because of the variations in the pricing they have kept for a triple and quadruple, which makes them choose.
Actually, no. Actually, you know, because the kit is now integrated, the variation is also not there.
Not there, yeah.
But the labs say that obstetrician say, nahi, hame quadruple nahi karana, hame triple karana. I don't know where is the gap.
Anyways, this will be dealt with iron hands.
Thank you so much. Thank you for such a wonderful talk. I would like to thank the chairperson and the speaker for the session. Moving on, let me introduce a second guest. Second chairperson, Dr. Poonam Lumba. She is a director at Lumba Hospital and IVF Center at Ambala. She's also chairperson at Haryana chapter of ISAR 2011-2015. She's been an honorary librarian ISAR 2019-2020 and an AFOG ultrasound committee member 2020-21. She's an ex-president of IMA Ambala Cantonment, and she's also been in an editorial board of Journal of Human Reproductive Sciences. She's been a president of Foxy chapter of Ambala. She's received multiple awards, and I would request Madam to join us. Welcome, Madam. Dr.
Thank
Sashmita
you. Thank you. I'm already there.
Das.
Thank you.
Dr. Sashmita Das, she's a senior consultant at Utkal Hospital. She's also been a past president at Karimgar OBGYN Society. She's been a gold medalist. She's got various publications under her kitty, and she's been a president NGO 20 years. Welcome, Madam. I would request Dr. Lumba to introduce our second speaker.
Yeah. So our second speaker is Dr. Chinmay Ratha. She's MS Director, Resolution Fetal Medicine Center, Navodaya Hospitals, Senior Consultant, Fetal Medicine and OBG, Yashoda Hospital, Secunderabad, Fetal Medicine Foundation, approved trainer in India, RCOG moderator for ERP MRCOG2 exam, ICOG Foxy certification course, Center Head for Fetal Medicine and Donald USG courses, awards and publications. She has received Dr. Rajat Ray Fetal Medicine Award, Foxy 2019, Foxy Young Author Award for best paper published in Journal of OB-GYN in 2008. Then she has received other awards as well for best paper prizes. And she has co-authored the book on MRCOG2 exam. So we welcome Dr. Chinmaya for your talk.
Thank you. Thank you so much, Madam. So at the outset, I thank Dr. Komal for this opportunity to be among friends again. And the topic that she has given me is one relating to multiple pregnancy and somewhere where one of the twins is in trouble. So we would not expect drastic decisions if one of the babies is normal and one of the babies has problems. And I will bring forth some of our clinical dilemmas that clinicians have to handle in this situation. So am I sharing my screen?
Yes, we can see that.
Thank you. So this is a situation called one twin in trouble, dilemmas in multiple pregnancy. So whenever there are more than one babies in the uterus, just now we were listening to aneuploidy screening, and Selva made a comment that, you addressed multiple pregnancies because multiple is always a bigger problem. You don't know, what parameters to use. There are always special considerations needed for multiple pregnancies. Now, this is one situation where you have two babies inside and they run parallelly on tracks, and just like this we used to have these train animations. If one of the babies is in trouble and it derails itself, the whole pregnancy can be in a lot of trouble. So even if one baby is in trouble, the obstetrician is in big trouble. First and foremost, we don't talk about twins unless we define chorionicity. In any fetal medicine discussion, before we start talking about twin pregnancy, you must remember that there are no twins. There are only monochorionic or dichorionic twins. So every time an obstetrician says this is a twin pregnancy, the fetal medicine doctor will ask which type of twin pregnancy. So those obstetricians who work long enough with us, they define it. It's a DC twin pregnancy or an MC twin pregnancy, because this definition of the type of placenta or how many placentas are we dealing with. If you have just one baby, one placenta which is feeding both the babies, for example, this one up here in the sepia, you can see that there is a T sign. And this means that there is a monochorionic arrangement here. So both the babies are sharing one placenta, whereas here in the picture down there, you see that's a lambda sign. And that means these two play babies have their own placenta. So babies who have their own placenta are independent and they will not affect each other as much if they have problems. Whereas if it is a common placenta, then whatever happens to one baby has a profound effect on the other one. So based on the number of placenta and the number of sacs, we define pregnancies as monochorionic, dichorionic, monoamniotic, or monochorionic diamniotic. So when we talk of twin trouble, that means one of the babies is in trouble. We will always make sense when we talk about clinical situations. After all, we are all clinicians, and it is the clinical dilemmas which appeal to us the most. So this is the first pregnancy of a lady who's 38-year-old, and she's had previous two failed IVF. My chairperson is from the IVF background, so she can understand that how much it terrifies women when they get pregnant after multiple failures in IVF. So she's this time conceived a dichorionic diamniotic twin pregnancy. And since Sita ma'am told all of us to do a screening for Down syndrome, she was told to do that, but somehow she missed the first trimester screening. This is very, very common in our scenario where people miss the double marker screen. And then she comes for a TIFA scan and the fetal matrix. Okay, so on the TIFA scan, there is a hypoplastic nasal bone in one of the twins. Now, what do? One of the babies has a problem, the other one does not. So what investigation should we offer this woman who has no screening in the past, but there is a hypoplastic nasal bone? Everything else is normal. So if we offer her amniocentesis, we have to do amniocentesis for both the babies. This is a dictum for twin pregnancies. We can never rule out monozygosity even in dichorionic twins. So the babies might have originated from one zygote. They may have had different placentas also. So any baby having a problem, you should check both of them. But to check both of them, you have to put in the needle twice, and that doubles the risk of miscarriage. So it is a big dilemma for the couple as well as the obstetrician, because there is just one marker. And just now we heard Dr. Sita say that there is literature coming up saying that if isolated hypoplastic nasal bone, you may think mostly of Down syndrome, and other things are a very, very rare possibility. So after a lot of counseling, they decided to do the NIPT. Now, in twins, do we do NIPT? Well, yes, we can do NIPT in situations like that, where primarily we want to rule out Down syndrome, because the couple decided that let's not look for the rare causes. Let's trust in faith and just look for Down syndrome, because that's the commonest association. And they went ahead and did the NIPT. And the NIPT, somebody is still having, I think, can we just mute ourselves? Dr. Shail Kaur, can we just move your thing? Thank you. So the results came back as low risk, and that indicated that there is a very, very low possibility of having Down syndrome. And then she went ahead, continued the pregnancy, and had a good outcome. So can NIPT be used as a triage in twins? What are the recommendations? So in this particular case, we did use it. And if you go back and see the ACOG practice guidelines of 2018, it says that, yes, it can be used for twins. And in fact, for trisomy 21, it is as good as for singletons. So how does it work for twins? You do an NIPT. If both of them are normal, or both of them have trisomy, or one is trisomy or one is normal, these are your clinical possibilities. So if you get a normal result, that is a low risk result, you know that none of these babies or their placentas have any composition of Down syndrome. So you're not worried. You can avoid an amniocentesis. If it comes as high risk, just like we heard now for the singletons, if it comes as high risk, we end up doing an amniocentesis for both. But in that condition, the chances of finding a problem are also very high. So that kind of justifies the invasive procedure. And if there is NIPT is low risk, you can avoid doing 2 procedures. So when one of the twins gives you some kind of a marker and you want to avoid putting both the twins at risk of miscarriage, you can opt for doing an NIPT. There are some other cases like this, where this is a lady who came to us again with an IVF conception, dichorionic twins, and her first trimester result is like, shoo, very high. You just look at that. The risk of trisomy 21 is more than 1 in 50 on the Priska software. That is the cutoff. And after a lot of counseling, she underwent a lot of dilemmatic moments and then finally decided to do amniocentesis. So we did the amniocentesis. Uh, Trisomy 21 was ruled out for both, but unfortunately, one of the babies had a abnormal microarray result. We just learned right now that microarray can give 5% more information than regular karyotype. And it was a surprising result that there was a kind of deletion on chromosome number 4. And that was classified as likely pathogenic. After decision with the geneticist, they did not want to have that baby. So they underwent a selective reduction of that one twin, continued the pregnancy, which was then delivered as a singleton with a term baby boy, 2.5 kg. The other problem we have with twins is when one twin grows less. So a twin might be in trouble because of high risk of aneuploidy. A twin might be in trouble because of less growth. And discordant growth is by far the commonest problem we see in multiple pregnancies. When do we call it discordant? When there is a 20% or more discordance in CRL in first trimester, or in the estimated fetal weight after 20 weeks of gestation. Now, whenever we measure twins, we put the biometry of both the people, both the fetuses together, and then calculate the disparity by dividing the weight of the larger twin from the weight difference in the weights of the both babies. So whatever is the weight of one baby gets subtracted, and then you divide it from the weight of the larger baby. So you get a percentage. So this percentage is 24%, and hence this particular case is a case of selective growth restriction. So we plot these graphs in serial comparative charts, and then we move on to see whether the disparity, if you look at this part, the estimated fetal weight, the last block of the chart, you see when the pregnancy started, at that time, I'll see if I can show a pointer here. Yeah. So when the pregnancy started, at that time, both the weights are kind of congruent. But when you go there, there is a disparity. One is going below the 50th centile, the other one is going above the 90th, above the 50th centile. So that the problem can happen. And if there is selective growth restriction, you need to make sure that everything else is fine. Detailed anomaly scan, ruling out infections in that particular pregnancy, and if necessary, an amniocentesis to rule out chromosomal abnormalities. Now, when there is monochorionic pregnancies, you may have a special type of growth restriction where everything else is normal, but one baby is selectively small. So whatever the type of chorionicity, the final decision will depend on the Dopplers. So you look at the Doppler status and decide whether or not you can continue the pregnancy or you need to deliver. Now here comes the problem. If it is a dichorionic twin pregnancy and one of the baby is small for dates, but it has normal Doppler, you can continue the pregnancy. If one of them is small, but it has an abnormal Doppler, then what do? If you deliver it very soon, you are delivering the normal baby too soon, very preterm. If you continue, there might be an IUD. Now, if you have an IUD in a dichorionic pregnancy, the effect on the other one is very less. But the same situation in a monochorionic pregnancy will throw you away, because if you have an IUD in a monochorionic pregnancy, then the risk of neurological deficit in the surviving twin is good about 25 to 26%. And that is why when it is a monochorionic twin pregnancy, your decision to deliver or wait will depend on the smaller baby. Whereas in the dichorionic pregnancy, your decision to deliver on weight or wait will depend on the larger baby. So in monochorionic twins, we classify the selective growth restriction into three types, where the type 1 is with normal Dopplers and hence has a good prognosis. But the type 2 and type 3, whether it is completely absent flow or intermittently absent flow, has a poor prognosis and a risk of neurological deficit. So whenever there is any kind of one twin in trouble with regard to the growth and Dopplers, you have to undergo a very, very thorough assessment of the case and talk to the parents with the neonatologist, assess chorionicity, gestational age, neonatal care, and parental wishes, and take a decision of whether to give expectant care or deliver the babies preterm, or if possible, do what is called a cord occlusion, especially in monochorionic twins with type 2 and type 3 IUGR. Because if you don't do that, you will leave behind a baby who will survive, but survive with neurological deficit. So there are other conditions where one twin might be in trouble, for example, structural abnormalities. Now, this is a baby where, again, it was a DCDA twin pregnancy, but if you see, one of the babies started developing a ventricular aneurysm. Just look at this cardiac ventricle on the left side, and this was growing bigger, and that aneurysm was becoming more and more prominent as the baby was growing. Now, at 26 weeks, we noticed it for the first time, and then the baby and the patients underwent very detailed counseling. There was a risk of IUD if it had grown too much and caused cardiac failure, but they decided to continue the pregnancy. And why were we okay with it? Because this is a DC, dichorionic twin pregnancy. So luckily, this pregnancy went off well. They continued the pregnancy. It did not become too dramatic as the pregnancy progressed, and she delivered both the babies at full term. And the male baby who had the aneurysm was subsequently operated and had a good outcome. So this was another interesting case where there were two babies to begin with. Then suddenly I was called that there is a cervical pregnancy, and that pregnancy needs an urgent assessment because both the babies, both the sacs seem to be of the same size. And by the time the patient came to us for a cervical pregnancy, she had started bleeding and we were very worried. But when I actually did the scan, I could see that the lower sac was in the cervical canal, not in the cervical tissue. It was actually in the process of expulsion. So we did not do anything. We did not do anything. We just waited. And one sac overnight expelled itself through the cervical canal, whereas the other sac remained in utero. And this woman went on. She went on till 31 weeks when she had a PPROM and delivered a 1.1 kg baby who's healthy and doing well. Sometimes you have twins with one major abnormality. For example, this is a dichorionic diamniotic twin pregnancy with one baby having a major encephalocele. Now we know that the prognosis is very bad and this will have neurological implications, and parents usually would have opted for termination if this was the only fetus that they were carrying. However, there is another healthy baby there. So what do? In such cases, we offer selective fetal reduction, ultrasound-guided insertion of potassium chloride intracardiac, which allows them to have one baby, at least, which goes on successfully. Now, the same cannot be said when there is monochorionic pregnancy. That was a dichorionic pregnancy, we could do that. But in monochorionic pregnancies, there are vascular connections between the two babies. So we cannot use potassium chloride. So this was a case where it was a monochorionic twin pregnancy where one of them had major structural abnormality. So in this case, we did an intrafetal laser and coagulated the cord of the abnormal fetus, and that pregnancy continued. Similarly, this is another situation in twins, especially monochorionic twins, where the other baby is anomalous, but actually it's also amorphous. You don't even have a proper structure for the second fetus. And this is not even a true fetus. It is what is called a trap sequence, a twin reversed arterial perfusion. So if you see, you will see one baby which is completely well formed, and the other one is just a mass with some organs which are not exactly properly formed. So in these cases, you just wait and watch and see if the trap is growing very big. So this particular case, the trap was growing and it started becoming very big, where it becomes almost the size of the abdominal circumference of the other baby, then we need to intervene. Otherwise, this is an acardiac mass. The normal baby also goes into heart failure. So in this particular case, we decided to do a radiofrequency ablation to ablate the feeding vessel of the trap. That was ablated and that pregnancy went on, and she had a PPROM at 31 weeks and had a 1.1 kg baby who's otherwise doing well. If we had not intervened at that time, it would have caused hydrops into the normal surviving twin, because that was the heart which was sustaining even this mass. Sometimes we have situations like this, which is a monochorionic, monoamniotic. There is no intertwin membrane. Both the umbilical cords are attached very close to each other, and one of these babies has an anencephaly. So again, one baby is normal with a good fetal head, and the other one has an anencephaly. So again, in these cases, we can't let the other baby be in trouble because of one anomalous baby. So here we did intrafetal radiofrequency ablation, cord ablation. And finally, she delivered the baby at 36 weeks with the normal baby surviving and the anencephalic baby just ablated there, who continued to be in utero till the baby was delivered. This is another situation where a 26-year-old primigravida was referred at 19 weeks for twin-to-twin transfusion because it was an MCDA twin pregnancy and there was some fluid discrepancy. It was thought to be twin-to-twin transfusion. When we noticed this pregnancy, we saw that we could see the bladder in both the twins, and the deepest pool was 1.8 and 5.7. So there was not really that much of polyhydramnios, and there was a discordance of about 22%. So we thought this is not twin-to-twin transfusion, and we looked very carefully. We thought this is a case of selective IUGR because the abdominal circumference was distinctly different in both the babies. So we asked the patient to come back after 2 weeks because that is the normal follow-up of MC twins. But then in India, this is a very common scenario where they don't come after 2 weeks, they come whenever they want. So they came back after 26 weeks, and by the time they had had another scan somewhere, and the doctor told them that, oh, it is again twin-to-twin transfusion, and now it's become more severe and you need immediate intervention. So this was like 7 weeks from our initial findings. So again, she came and said that, no, this is twin-to-twin and you didn't intervene, now please intervene. When we looked at the babies again, the Dopplers were normal. The twin-2 was continuing to grow along the lower centile, but what we saw was, although there is polyhydramnios, there was a hyperechoic mass in the left lung of twin-1. So if you see this mass in the thorax of one twin, you have a large echogenic mass, and that was pushing the heart to one side, and that is nothing but a cystic pulmonary airway malformation. So what we did was, because the risk of hydrops was still low, we counseled the patients and we just continued the pregnancy expectantly. You can see this big mass in the thorax of one of the babies, and that was the cause of the polyhydramnios. This was not a case of twin-to-twin transfusion. This was a case of one baby having a CPAM, and this is correctable. This has a good prognosis, so there was no need to intervene. So we did not intervene. We continued the pregnancy as such, and some role of prenatal steroids is there, so that was given. And finally, they came for regular checkups and delivered at full term. Both the babies, one of them was 2.26 kg, one of them was 1.9 kg. And the first baby was admitted in NICU. Pediatric surgeon operated on this baby. So you can see that CPAM mass there. And there was a lobe which was having that CPAM, and that was operated. And finally, the baby did very well. So this had a very, very good outcome. So I'm just going to show you some bits of the surgery in the newborn, because we don't do these surgeries in utero, but as soon as the baby is born, it can be evaluated by the pediatric surgeon, and then they can do that. And this is the excised part of that CPAM. So they had a very good outcome, and they were very happy because both the babies they could take home. When we reduce pregnancies, we lose one of the babies, and these babies didn't want to do it. So the learning points are, don't think of TTTS in every MCDA with polyhydramnios. Look for the unexpected causes and counsel the patients regarding all the options with a multidisciplinary team in place. So whenever we have one twin in trouble or discordant twins, we must see what are the factors that we cannot modify and what are the factors that we can modify. So what we cannot modify, there's no point, worrying about it. What we can modify is optimal surveillance, following a good protocol for management, counseling the patients about all the options, and arranging optimal neonatal care in cases of preterm birth or anomalous babies who need postnatal surgery. So when one twin is in trouble, there are lots of dilemmas in multiple pregnancy, but making a decision is always the most important thing from the obstetrician point of view. And you should do it with just one goal in your mind, that this pregnancy belongs to couples who have some expectations. What is their expectation should be the center point of our decision of what we should do in that pregnancy. Because the first principle that we have to follow while managing our patients is first do no harm. Thank you very much for a very patient hearing.
Thank you, Dr. Chinmay, for such a wonderful and informative session. If there are any questions from the audience.
Dr. Chinmay, hi. It was a very excellent talk. And I had one question that he talked about an anomalous fetus. So till what gestational age you can use the intracardiac KCL? If the gestational age is advanced second trimester, can we use it?
Yeah, so intracardiac KCL, see, we use it whenever we detect the abnormality. So in the first trimester, we are very happy to do it up to 14 weeks. In the second trimester, usually the situation arises if there is a anomaly that has been detected after the second trimester TIFA scan. So up to 24 weeks also we have done it. But in multiple pregnancy with monochorionicity, you may have sometimes complications that come up even later. So we do the reduction even later because this is a method of continuing the pregnancy.
And if it is a dichorionic, you would still recommend?
The reason has to be very justified. See, in a dichorionic pregnancy, the most common indication to do a reduction is an anomalous fetus. An anomalous fetus which will have a bad postnatal life. So that situation only arises if you detect it at the TIFA scan. There are, we've not had any situation where we've had to do a reduction later on for an anomaly seen in a dichorionic pregnancy in the third trimester. There are very few indications that. So maybe Dr. Vandana can give her inputs in this. She has a lot of experience on late reductions. But for us, because I know aneuploidy screening-based reduction decisions are taken in the first trimester. Anomaly reductions are usually done in the second trimester. Third trimester reductions are mostly in the monochorionic zone where there is a progressive, change in the physiology, where you are stuck with a decision of either doing a cord occlusion or delivering the babies in a very, very, premature situation. So mostly we have done cord occlusions in third trimester, but not KCLs in the third trimester. Dr. Vandana?
Ma'am, you will have to unmute yourself.
I am with Chinmay in saying that till 24 weeks we would do reductions, whether it is DCD or MCDA. Later on, reductions will be very rare and mostly for monochorionic. If there is some kind of a selective FGR where we want to save the other baby. But for anomalies, we would do it till 24 weeks till the time of medical termination of pregnancy. We've done one for Down syndrome, which came up later on at 34 weeks. So that we had to go through court and do it at that time because there it was
but that was a singleton and you were doing it for termination of pregnancy, right?
No, those different, one twin also.
Okay.
Twin with one, but it came to us very late. By the time court gave us order, it was late. And so we did one reduction and one continued. So there's one case of all.
PK Shah sir is here. Maybe he'd want to give in some information.
Thank you, Dr. Chinmaya. You explained so beautifully.
Thank you.
We must admit that, maintaining the multiple pregnancies till the end is a great responsibility on our shoulders. And in each trimester, I think we should be very vigilant and our counseling should be, continuous.
Yes, ma'am. Thank you.
Thank you, Dr. Chinmaya, for such a wonderful talk. I would like to end this session by thanking all our chairpersons and the speakers. I'll hand over to my Dr. Anusha Devala to move forward for the second session, that is the panel discussion.
Thank you, Dr. Shruti. Yes, after such an informative session, so let us move on to much interesting panel discussion on fetal growth restriction. I would like to invite all the esteemed faculties. Dr. Bela Bhatt, madam. She is a chairperson, Fox Imaging Science Committee, fetal medicine consultant at Rainbow Women's Hospital in Andheri, Mumbai. She is fetal medicine consultant at Baba Saheb Ambedkar Hospital, FMF certified sonologist for fetal abnormalities, FMF certified sonologist for nuchal scan. She has received many awards, notably CS Dawn First Prize at AICOG Bhubaneswar, and one PCPNDT case in Bombay High Court by fighting it in person. Welcome, madam. She will be moderating the session today. Let us welcome Dr. BK Shah, sir. He was professor and unit head at Department of Obs-Gynae at KM Hospital, past Dean, Indian College of Medical Ultrasound, past president, IH, past president, Indian Federation of Ultrasound Medicine and Biology, past president MOGS, past president AF. It's an exhaustive list actually. Sir, welcome, sir.
Sir needs no introduction.
Sir needs no introduction, absolutely. He will be the expert for the session today. I would be inviting all the panelists now. Dr. Pragya Mishra. She is consultant fertility specialist at New Life Test Tube Baby Center, consultant MGM Hospital at Research Center. She is a chairperson Genetic and Fetal Medicine Committee, vice president Patna Obs-Gynae Society, secretary of Patna Obs-Gynae Society 1920, examiner for MRCOG clinical exam. She has received many awards, notably Asia GCC Award 2021, contributed many chapters. Welcome, madam. I would next like to invite Dr. Vandana Bansal, madam. She is additional professor at the Vadia Maternity Hospital, Mumbai, director Surya Fetal Medicine Center, Mumbai, obstetrician with super specialization, and she has 23 years experience in fetal medicine. She provides MUHS approved faculty for the fellowship program in fetal medicine. She is a national coordinator, Imaging Science Committee, vice president, Society of Fetal Medicine, Mumbai chapter. She has many publications in national and international journals and has won many awards. Welcome, madam. Next, Dr. Samata Raghav Rao. She is a senior consultant at medical director at Sri Satya Vijaya Hospital in Telangana. Past president of Mancherial Society of Obs-Gynae, past treasurer MSOG. Practicing for 20 years in Mancherial, where she provides secondary level care to the women, fulfilling a pressing need for community-based setting. Her academic interests include updating herself at several conferences. Her school camps have been particularly successful. Her current interests are aesthetic and reconstructive surgery, managing midlife crisis. Welcome, madam. Next is Dr. Pooja Lodha, madam. She is director at Kangaroo Cradle, the Fetal Care Clinic, lead consultant at fetal medicine and fetal therapy, university recognized trainer and thesis guide, 1-year fellowship in maternal fetal medicine at Bharati Vidyapeeth, Young Gynecologist Award 2019 she has received, and Dr. Shiri Zaftari Award also she has received many awards. Welcome, madam. Next, Dr. Shyama Devdasan, madam. She is a Fetal Medicine Foundation UK certified for anomaly scan, first trimester scan, ICO certified for a first trimester scan, Foxy trained in advanced infertility. She's gets a certificate in genetic counseling, Martin Luther Christian Society, Shillong. She is a visiting consultant, chief consultant in fetal medicine, Embassy Scan, Thrissur. And she's a secretary of Thrissur Obs-Gynae Society. She has received many awards. She's a member of Society of Fetal Medicine, Perinatology Committee. She's executive member of Kerala chapter of SFM. Welcome, madam. Next, Dr. Shayal Kumar, madam. She's a professor and in charge for high-risk antenatal unit. She's a Punjab Institute of Medical Sciences, Jalandhar. She is a member of Foxy Medical Disorders and Pregnancy Committee, academics chairperson in Foxy Jalandhar, and she has many publications in various national and international journals. She has contributed to chapters for active review. Welcome, ma'am.
Thank you.
Dr. Suma Vishnu, madam. She is a consultant in Obs-Gynae, Vinayaka Hospital at Kerala, founder, treasurer at Wayanad Obstetrics and Gynecology Society. She is a member of Perinatology Committee, Foxy, member Clinical Research Committee, Foxy, associate editor at KFOG Journal 2021, district coordinator, EMOCLS, organizing secretary of first All India Perinatology Conference, invited faculty to all Kerala and national conferences. Welcome, madam. Next, Dr. Mansi Shukla Khedka, madam. She is a consultant fetal medicine center at Dinanath Mangeshkar Hospital and Research Center, Pune. She has many affiliations, many awards to her name. She has received Dr. Kamini Rao Yuva Oration Award 2023 recently, Dr. Rajat Ray Award in Fetal Medicine in 2018, Foxy Traveling Specialist Fellowship in 2018. She has many publications in numerous national and international journals. Welcome.
So thank you so much, Anusha, for that exhaustive job of introducing so many of us. Well, at the outset, I would like to thank my dear friend Komal and Dr. Niranjan Chavan for giving me this opportunity to be part of this wonderful, wonderful webinar. There have been 2 wonderful talks by Dr. Chinmay and Dr. Sita, and we all have enjoyed. And now we are going to discuss about fetal growth restriction mainly in singleton pregnancy. And it's absolute honor and pleasure to have Dr. P.K. Shah, who has been a guiding force and pioneer of ultrasound in India. So every one of us would have a reference point as Dr. P.K. Shah. So thank you so much, sir, for being here as an expert. And then we have a galaxy of experts here. So many fetal medicine experts and so many experts of OBGYN in that field as panelists. So I think my job is easy. Komal, thank you for this wonderful galaxy of panelists. So can I share my screen?
Yes,
ma'am. No, this is showing something else. Basic advanced. What is this showing? Basic advanced files. Let me see. No. I've opened my PPT, but I can't see that.
Yes.
Sorry, the tech team, can you help me? Because I can't choose my file. I have opened my PPT on my...
Ma'am, kindly reshare it, ma'am. And while resharing, you need to click on screen window, ma'am.
Just a minute now. I need to get to the...
Please stop share, ma'am, and then reshare
Stop sharing first.
Stop share. Okay.
Now share again.
Let me make it full. Okay. Some technical problems are always there. Okay, fine. Now I think I should be able to see.
Yes, ma'am. Now we can see.
Yes. So we all obstetrician, fetal medicine consultants, we are used to some technical glitches, not technical, but clinical dilemmas. And so we are used to this. Okay. So first of all, let me tell you that we are all now used to the physical meet so much that doing this panel on this webinar made it little difficult for me. There are so many panelists whose name starts with S. So just for technical convenience, I have put short forms of the panelists so that we can initiate the discussion, and I think anybody can give their opinions in between. So my idea is just to touch upon some basic aspects of being able to diagnose fetal growth restriction in singleton properly, and then go on to the Dopplers and the management and the next level management of fetal growth restriction. So I have taken some case scenarios, but in that, what I have tried to do in the case one is to give a basic idea about how to, first of all, do a proper dating and diagnosis of fetal growth restriction, and then the management. So this lady, 28 years old with spontaneous conception, non-consanguineous marriage, second gravida, first para with first cesarean section, first male of 2 years. Her first amateur screening was low risk. 19 weeks anomaly scan did not show any abnormality or no soft marker detected. There was uneventful second trimester. Now, growth scan was done at 28 weeks, and that showed the EFW as 4th centile and AC at 5th centile. So with this basic information, keep losing the Zoom somehow.
Can go to the left corner for moving the slides.
No. I am losing the entire screen only somehow. Okay, fine. So, I think we'll start with Dr. Suma. Dr. Suma, can you just make a comment on, just based on this much information that is provided to you at 28 EFW with 4th centile, 8 at 5th centile, just based on this, what is your comment?
Yeah, a very good evening, madam. So happy to be a part of this panel, and I thank Komal madam for giving me a wonderful opportunity and to meet Bella madam, Chinmay madam, Sita madam over and over again. And coming to my case scenario, actually she's a 28-year-old lady, uncomplicated pregnancy, first trimester screen is negative with, I hope it is correct dates, and 19 weeks also, there was no abnormality detected. And at growth scan, it is found that her estimated weight and AC is coming at less than 10th centile. So definitely, as her growth scan is showing a growth potential or a AC or weight is coming at less than 10 centile, I would like to call her as a small baby or a small 4-day baby.
Right.
And the small 4-day baby is a baby whose gestation age is it is coming at less than 10 centile. And we don't know logical or whether it is a constitutionally small baby. So if we find a single parameter like till that everything was normal and at 28 weeks just she is getting a baby at less than 10 centile, we'll just call her a small 4 gestational age baby provided her dating is correct. That is very important, ma'am.
Yes, very true, very true. So that's a very important thing, that provided the dating was correct. So that's what is my next question. How do you confirm the dating? Suppose the patient comes directly to you at 28 weeks with this report. How do you first of all confirm the dating?
Yes,
What are the
ma'am. So
parameters you look at?
Yeah, I have to definitely go to the previous scans. If she has a good NT scan done at 12 weeks with the fetus in the right position, that is in the neutral position, if you can get a good image in that, then you'll be very much convincing, or you yourself have done that. It is we are very happy with that. Or else you have to go to the image, you have to see that the fetus is on the neutral position with no hyperextension or flexion of the fetus. And if it is corresponding, then we can take into account that the dating is correct. Then if it is corresponding at NT scan and at 20 weeks, and now only the baby is showing a reduction in the growth potential, or if the baby is at less than 10 centile, then we can categorize it as a small 4 gestational age baby.
Wonderful. For this particular case, yes, we had a good NT scan done. We had second trimester anomaly scan. So we had no doubt about the proper dating. And therefore, we knew that the centiles were correct. It was a small for gestational age. And for any other case, suppose the patient has conceived out of IVF, then we know that we have a date of conception. And based on that, we can have a proper dating. And then, so basically, the idea is to make a point here that dating makes a foundation to diagnose a fetal growth restriction. Unless and until you have a proper dating, you can never diagnose fetal growth restriction. Okay, fine. Now this is a small for gestation age. I want to know whether it's really just small for gestation age or there is something wrong with the baby. It's a pathologically small baby with fetal growth restriction. So, Dr. Shyama, can you please tell us how can you differentiate between these two?
Very good evening, madam. Not taking up much time with the intro part, but still thanking Komal madam and all of you all for giving me this wonderful opportunity to be a part in. Now, coming back to the question, as you just rightly said, Dr. Suman was mentioning about the SGA babies. When do we call that? Like, if we are happy with it being only an SGA, the Dopplers are normal, the lighter is normal. There is no, as you had mentioned in the first slide, madam, about the anomaly scan being normal. There are no other features of increase. Nothing abnormal with the baby except that the baby is small. That is when we will differentiate as a but the moment you reveal that it is an FGR fetus, that is when one is the fetal weight. That is what is the most important. Weight falling less than third centile. Along with that, if at all the baby is just below the 10th centile, but along with that, if we find an abnormal Doppler values, this is when that comes into play. Doppler is abnormal, then you call it definitely. You call it an FGR fetus, and depending upon the gestation date, it goes into early or late onset.
Yeah. So thank you so much for that clarity. So basically, what we want to stress here is that we know that all small for gestation age are not pathological fetal growth restricted, because we know that 70% are normal or constitutionally small. 20% of them, as I had put here in the slide also, 20% would be because of abnormal uteroplacental insufficiency, and 10% would be abnormal small because of either chromosomal, structural, or infection, right? So we obviously rule out other causes and then look at the Dopplers. And of course, we also always, when we are doing scan and we can find there's a SGA baby, look at the size of the parents as well. If there is a short statured mother or parents are small, then there are more chances that it would be constitutionally small baby. So we have to keep that in mind. Doesn't mean that there is no FGR in these babies. There can be, but that is one point we keep it at the back of our mind. And of course, we have the other causes. Okay. So very beautifully mentioned by Dr. Shyama and Kumar that this is how we differentiate between the two. Now, we know that if we have to manage a fetal growth restriction, we have to now know about the types of fetal growth restriction and how important it is and what are the different types of fetal growth restriction. Dr. Mansi Shukla, can you please throw some light on this?
Yes, ma'am. Good evening. I express my gratitude to Komal Madam, Niranjan sir, and I'm heartened to see my seniors, PK Shah sir, Vanda ma'am, Chinmay ma'am, Bela ma'am, all my seniors and colleagues. So fetal growth restriction is divided into, very arbitrarily, it has been divided into early and late according to the phenotype. That is 32 weeks has been the limit. Less than 32 weeks is an early IUGR and more than 32 weeks is a late FGR. And more common would be the late FGR, which happens in around 70% babies. The challenge in the early FGR lies in the management part because we've already diagnosed it. But in the late FGR, usually the challenge is diagnosing it because it's a very fickle entity. And the placenta is affected in the early FGR in the form of bilitis and fibrin deposition and whatnot. And those changes can be seen as a uterine artery high resistance or umbilical MCA DV. Even DV is affected because the heart is pumping blood against a high resistance of placenta. So the DV gets affected. Whereas in the late FGR, because the brain is more susceptible to the hypoxia, it affects the cerebroplacental ratio. So the MCA and the CPR take precedence in late FGR.
Yes, we'll come to that. So basically, yes. Thank you so much for basically putting it in front of everybody that it is the early onset fetal growth restriction where you'll find more of abnormal Dopplers. So the diagnosis is easy, but management is difficult. Whereas late onset that occurs after 32 weeks, the placental damage is less than 30%. Therefore, your Dopplers wouldn't be that abnormal. So picking them up is a very, very tricky. We have expert Dr. Pikesha sir here. Sir, any comment of yours on this?
No, I think it's something very good that has happened to us because previously we did not know that there are two types of FGR. So now we know very clearly that in one, you have a series of events occurring as far as Doppler is concerned. Whereas in the other one, you may have even umbilical artery Doppler showing you normal. So that does not mean that everything is all right after 32 weeks.
Right.
So there is a good paper from England, London, that they feel that it is a must to do color Doppler in third trimester scan because these late FGRs can be picked up by doing color Doppler of both umbilical as well as middle cerebral artery. That will pick up these cases of late FGR because very difficult to pick up the late FGR otherwise.
Thank you so much, sir, for your expert comment because we know that now the significance of doing growth with Doppler at 32 weeks and 36 weeks. And I'm sure Dr. Vandana Bansal, Dr. Pooja Lora, everybody agrees with what sir has mentioned. So yeah, continuing with Dr. Mansi, how do you define fetal growth restriction based on Dopplers? We all know now we follow the International Delphi consensus. So can you please, because see, these are things which are important for everybody, those who are scanning, those who are not scanning on their own. Managing fetal growth restriction without knowing the stage-based classification is impossible. So we must all know about it. Yes, Mansi.
Completely agree, ma'am. The staging is very important both for fetal medicine specialists, radiologist, and the obstetrician taking care. And first of all, I would like to point out that the fetal growth restriction is not just the smallness of the baby or Doppler changes. It is actually the inability of the baby to achieve the growth potential that it already has. And so, but we need to quantify it. That is why this Delphi consensus has come about. And in this, the early FGR is, so there are certain solitary criteria, such as an EFW or an AC length percentile, very small baby. If we would directly call it as an early onset FGR, less than 32 weeks. Or umbilical artery, absent diastolic flow, again, a solitary criteria. Then there are certain contributory criteria for early onset. That would include the uterine artery high resistance, the umbilical high resistance, or the AC or EFW falling at the 10th centile. So any two of these criteria would again be or FGR, early onset. For late onset, there is some difference. There would either be a severe fall that is less than third centile, or quarter 3, there would again be an umbilical high resistance or a cerebroplacental ratio that is affected, that is the Doppler changes, or a baby that is less than 10 centile. And then one more criteria they've added is more than 2 quartiles fall in the weight of the baby. That is the EFW or the AC. By 2 quartile, you mean that whatever it is, 25%, 25%, 50% fall.
So I think classification, thank you so much, Nancy, for making it clear. So I think from this classification, one thing is very important for every one of us, whether we are scanning, we are getting reports from a sonologist, that what is important from diagnosis of fetal growth restriction point of view is the expected fetal weight, abdominal circumference, centiles. We have to have centiles in the report. We cannot have 32 weeks, 3 days and 32 weeks, 31 weeks, 3 days. We cannot make out the diagnosis of fetal growth restriction by comparing the gestational weeks by LMP and by sonography. No. We have to have a proper dating scan. Based on that, the centile of growth in this particular scan, and then look at the centiles and make the diagnosis. Along with that, in Dopplers, what is important, as you can see here, is PI index of uterine artery, umbilical artery, and MCA and CPR. Only this indices are important. Do not look at other indices and get confused. Only these things will help you classify into the whether it is first, second, third stage of fetal growth restriction. Okay, so I think that is very, very clear here. Now, we've discussed how to differentiate between a small for gestation or constitutionally small baby from fetal growth restriction from placental insufficiency point of view. So both Dr. Shyama and I'll have to refer Dr. Suma. Is it important to differentiate between these two? Does it make any difference as far as management is concerned? Can you please discuss that out?
Definitely, madam. Actually, SGA is just a constitutionally small baby. It is not pathological. But the point is that we have to differentiate whether it is going in for an FGR, because FGR is definitely a pathological situation. And only if we do a correct follow, we'll be able to differentiate between the SGA and a FGR. And the management is totally different, because the Doppler's abnormality, the Leica abnormality, everything can come in for an FGR rather than an SGA. So our decision for termination, our management, everything differs between SGA and FGR. So definitely we have to differentiate. I think Shyama can add on that.
Yeah, and one more point apart from this, what I wanted to mention is about SGA babies also. Like once you find out that it is an SGA, you shouldn't be less worried or anything. Yes, FGR has got its own management course. It's on the surveillance pattern. It's all different. But at the same time, for SGA babies also, we have to keep in mind that towards the end, you have to counsel the patients and the couple. The neonatologist has to be pulled in, because postnatally also SGA babies, they have a higher risk than the normal population for even a fetal death, IUD also. Higher, I think about around 1.5% higher than the normal population. I don't remember the exact wordings, but yes, so along with that, the hypothermia, all the complications postnatally, hypothermia, hyperbilirubinemia, all that.
So the neonatal outcome is different, one thing. And second thing, we have to follow up these SGA babies, because some of them may turn as a late onset fetal growth restriction in the third trimester. We may have brain sparing. So we have to be very, very vigilant if we want to prevent those stillbirths in late gestation, right? In the late third trimester. So thank you very much for bringing out that point. That's very, very important. Now, do we have Dr. Pooja Lodha? I couldn't see my friend. Dr. Pooja, in this particular baby, obviously we have already discussed as to how do you diagnose fetal growth restriction and all that. So we just know about the centiles of growth. So what would you offer next? And what all is important in that? Do we have Pooja? Has she joined?
Pooja has left for some
emergency. So Dr. Vandana Mansal, can you please...
So can I go back to the previous slide?
Yes,
so,
sure.
So our growth at 28 weeks, it's a low risk patient. The weight is on the 4th centile. So I am still wanting to understand whether it is constitutional small or it is a growth restriction. So I will want to look at the Leica and also the Doppler. So the Doppler is going to tell me whether I call it as FGR or not, because fourth centile means I need to have more parameters. So I need a uterine artery Doppler to see. I'll need an umbilical artery to see, and MCA maybe also is required. So as you are showing me, the umbilical arteries are normal, MCA is okay, uterines are also normal. So at the moment, I'm going to put it as constitutional small baby, but it is on the fourth centile. So I'll not just leave it and say that we don't do anything, as what Suma and Shama also said. I would want to follow it up. So maybe in about 2 to 3 weeks, I will want to monitor the growth on a graph. So I put it on graph to see what is happening to it. And at the same time, also look at the Leica.
Yes. So Leica was adequate in this particular, the graphs I will be showing at the end. So this is at 28 weeks. So as Madam mentioned, yes, I wanted her to come back after 2 weeks, and she did come at around 29 weeks, 5 days. And now the growth is at second centile, just from 4th to 2nd. Dopplers are still normal. Now, can I ask Dr. Shail Kaul, who is Dr. Shail Kaul?
Yeah. Yes, ma'am.
Yes. Can you, how much concerned are you at second centile? The baby is at second centile at 29 weeks, 5 days. Are you worried? Are you alarmed? Are you okay with it?
Ma'am, since there is a change in the growth pattern and the growth curve is not conforming to what is expected from even from an SGA baby, it is definitely a matter of concern. But if the Dopplers are normal, I would reassure the patient that she just has to be more vigilant, and we would probably call her back in after 2 to 3 weeks to reassess whether there is any worsening of her growth patterns or for her Dopplers. So that is
what you would like to follow her up, right? You are not very much worried. It is a second centile and I would like to deliver this baby.
No, ma'am. She needs intensive monitoring now.
You would deliver based on?
Mostly on her Doppler parameters.
Wonderful. Thank you so much. Because many obstetricians, second centile pe growth hai, baby is so small, we shouldn't wait. Now we have Dopplers to help us, and that will tell us precisely how many weeks we can pull in this pregnancy. Dr. Samantha, would you like to comment?
Ma'am. Yeah. Good evening, Dr. Bela, ma'am. Yeah. Thank you, Dr. Komal, and thank you all my pioneers and I'm very happy to be sharing the screen with Dr. Shah, Dr. Chinmay, Dr. Sita, ma'am, and good evening, Bela, ma'am. Yeah. 29 weeks, 5 days, and expected fetal weight is on second centile. Dopplers are normal. Then we are concerned. Maybe a close follow-up and close surveillance, and ask her to follow up every 15 days and keep a close monitor on our fetal kick count. And report to us if any emergency within 1 week, otherwise 2 weeks.
Okay, so now we know that the growth is at second centile. Yes, sir.
It has become FGR now.
Bella, can I say something?
Yes,
it's become FGR.
Yeah, see, because you have to see in such patients the interval growth, which is very important. If the interval growth is good enough, you not to worry much about this baby. Otherwise, if it is not, then only you are worried. Doppler might be normal, but you require more repeated follow-up of this patient.
Very true. So here comes the role of the growth chart that we keep talking about, that every growth scan has to have a growth chart in the report. If it is not there, please ask from the sonologist, because that's the only thing with which we'll come to know, as sir mentioned, about the interval growth, whether it is on the same centile, whether it is dropping, falling, that we can come to know. Now here, as you can see, only SEFW less than third centile is your early onset fetal growth restriction. So here it is on second centile. So by definition, it is now
FGR.
Stage 1
fetal growth restriction.
Right? Now comes a very important message here. How do you report it at this stage? If you are a sonologist or a fetal medicine expert, how would you report it? And as an obstetrician, how would you want the report to be, so that you get guidance as to how much the pregnancy can be prolonged? So let's start with Dr. Shail Kaur. Whenever there is fetal growth restriction, and do you do scans on your own, ma'am? Dr. Shail Kaur?
No, ma'am, I don't.
Okay, so you send it to sonologist. So when you send it to a sonologist, what do you expect in the report of a Doppler or a fetal growth restricted baby?
So basically, when we're looking at the Dopplers, we're looking at what are the changes in the flow patterns to the fetus and what is the risk of developing hypoxia in the near future more than anything else. And we'd look uterines, umbilicals, and then progress forward accordingly.
So basically, you want to know, let Dr. Vandana Bansal give her inputs. Dr. Vandana Bansal?
So I think we have stopped giving the reports as corresponding to this weeks of gestation. So first information is we don't keep changing the gestational age. We need to give centile. So here, as you had put it in your report, it is second centile. So I will say that this baby is 29 plus 5 weeks and it is on the second centile. There is a dropping centile and we will call it as fetal growth restriction with normal Dopplers and normal Leica. And I would also suggest that we need to do more intensive monitoring, and probably because now it is FGR, I will call her maybe every week. That is how stage 1 FGR is to be managed. So now rather than calling in 2-3 weeks, there is a drop in the centile. I'll call her every week to see what's happening to the interval growth, what PK Shah sir is saying, that I want to see whether it's more falling down even if the Dopplers are normal.
Thank you so much for valuable input, Dr. Vandana Bansal. So in your report of a growth scan and a Doppler, number one has to be whether the gestational age is as per the dating done at either nuchal scan or proper dating, one thing. Second comes the centile, no second weeks as per ultrasound. So centile of growth now. Third comes in the Doppler, as you can see, only the pulsatility index of uterine artery, umbilical artery, DVPS, if needed at all, and CPR, right? So we look at the centiles of all this for the decision making, to look at the stage of fetal growth, because as we have seen in the definition, we'll need all these values to put in the stage of fetal growth restriction. And then based on this, we can decide. So as Dr. Vandana Bansal has rightly mentioned, this is stage 1. So we have to call weekly for the follow-up. And so we have, okay, fine. So that was about the placental cause we were talking about. Just to finish the discussion about the causes of early fetal growth restriction, well, Dr. Vandana Bansal, in any case, this was at 28 weeks. Still, would you like to know the cause of early fetal growth restriction? Is it possible the Dopplers are looking normal? So can there be some other cause as well?
So definitely in this case, because the Dopplers were normal, I am a little worried about looking at the structure of the baby back. Although an anomaly and a screening test has been done, I will re-look at for any markers. I'll look at for fetal infection markers. So any echogenic bowel is there, or if I see some ventriculomegaly, if I see thick placenta, if I look at calcifications in the brain or in the liver, I will be worried. So fetal infection, I'll re-look at structure. If the uterines are normal, I'm thinking it could be not placental insufficiency. It could be some other cause. But 29-30 weeks, I may not do an invasive testing unless it was very, very early at 20-22 weeks. So here I will, if no structural anomalies and no markers, I will follow it up.
Okay, so very, very important points here that you have to re-look. Don't think that everything was normal in the anomaly scan, no markers were there, no structural anomaly. There are evolving anomalies. Sometimes we find double bubble later in the second trimester and third trimester. So duodenal atresia. There are many evolving anomalies which we may pick up later, which may be indicative of some of the chromosomal abnormalities. So yes, you have to re-look at the structures and the markers, which were not there in this particular case. But still, the patient was counseled that, yes, we can offer invasive testing if you want, but as this we have discussed already, but this particular patient, the patient did not want anything. Okay, fine. So patient did not want any invasive test, and therefore we just did a maternal torch to rule out, and that was negative. That's it. Now, at 29 weeks, 5 days with stage 1 fetal growth restriction, we have the obstetricians here, and we have Dr. Pragna Mishra also here. Dr. Pragna Mishra, can we hear from you?
I think she's given her apology.
Oh, is it? Okay, fine. So, Dr. Shail Kaur, can you please at this stage, 29 weeks, 5 days, stage 1, what would be you thinking as far as management of this particular baby is concerned? When to deliver? How long you'll be able to prolong the pregnancy?
Ma'am, since her Dopplers are normal, then it would not be a matter of major concern. We would still explain to her the need for intensive monitoring at home through a daily fetal movement count, and she has to maintain good diet and hydration, rest. All of these usual routine things are advised, and we would advise her to come in for a checkup at least once a week, so that we can assess her in the clinic also.
As well as
if the Dopplers are absolutely normal, then we can wait for 2 weeks before we get another scan done for the Dopplers.
So by Dr. Vandana Bansal?
So I will want to monitor her every week, both for the maternal and fetal reasons. The growth might not change because the accuracy of a scan will not change much. But the Dopplers, I will still want to continue to see it, and also want to follow up the mother also, whether she developed preeclampsia or anything else that we have missed in the previous one. So I still continue to monitor, and maybe steroid once I decide to deliver at that moment of time, I'll give it.
Yes, steroids we would give only if we are planning to deliver in next week or so. So here, important thing is all the sonologists, fetal medicine experts, obstetrician, we all have to be on the same page, because the Grateco's classification of stage-based management of fetal growth restriction by Dopplers tells us that stage 1, do Doppler weekly, and then if you can pull till 37 weeks, you can pull, and then you can induce and deliver. So if we are all on the same page, we can counsel the patient well, and we can do the same thing. And here we want to prolong the pregnancy. It's just 29 weeks, 5 days. So we know it's too much preterm. And with every day prolongation in pregnancy, from here on, 1% improvement in the intact survival of the baby is there. So now this patient was called weekly, but as we all know in practice, some patient may not always follow us. So patient comes directly at 34 weeks, 2 days. The growth is still maintained at second centile. Dopplers are still normal. So how much we try to make a demarcation in, early onset, late onset, this is a case somewhere in between. You do not see changes. It is just the smallness of the baby, less than third centile. By definition, as early onset fetal growth restrictions, Dopplers are still okay. Stage 1, when to call back again? 34 weeks, 2 days. Mansi?
1 week, ma'am. Again, 1 week.
Yes. Dr. Suma?
Yeah, 1 week, ma'am, because we don't know when it is going to get abnormal.
Yes, so we'll be assessing Dopplers weekly, and at 30, after again patient comes after 2 weeks, at 36 weeks, 2 days. And this is the growth chart. So this growth chart itself is self-explanatory. Look at these centiles at 20 week scan, around 35, 37, and then going up and then dropping below 5th centile around 29 weeks. So that is the time when insult has occurred in the growth. And then it has fallen below 5th centile and then going down. So it coming to 2nd centile at 36 weeks, 2 days, right? So weekly we would like to call. And so it was 36 weeks, 2 days. Now, here comes the comparison. As sir mentioned about the interval growth, we also look at the Dopplers and the Doppler trend. So Dr. Shyama, the Doppler reports were all normal at 34 weeks also, at 36 weeks also, but this is the importance of the charts. So when you look at the charts, it clearly shows us something. So what does it tell us, Dr. Shyama?
Yes, ma'am. At 34 weeks, as it was already mentioned, all the umbilical, the ductus venosus, the uterines, all that comes as to be normal. 36 weeks, here MCA is also shown in the chart actually. It's not mentioned in this, but MCA, it's been shown. So in that also there is a drop. MCA, there is a drop, and uterine artery umbilicals there is an increase. But though it might not be abnormal as such when you look into it individually, this is where the CPR comes into play. That is why the CPR is one of the most important parameters towards the last, especially towards the end stages. When you have a dilemma, when to deliver, not to deliver, when to term it as an abnormal baby or Dopplers, CPR wherein MCAPI divided by the umbilicals, there you find it as an abnormal. Here, I think it was written as 4th centile, ma'am.
Yes.
So less than 5th, definitely it is abnormal. Severe hypoxia. I mean, it shows the severity of hypoxia, fetal hypoxia. So here, definitely 36 plus CPR is abnormal. You have to put in the patient, discuss about the termination of pregnancy also.
Bella,
yes, sir. Yes,
can
sir.
I say something?
Please.
See, you showed 3 charts. By not doing anything, if you show me these 3 charts, I know exactly how the baby is faring. But it shows trend that you have the uterine artery, PI going up, you have the estimated fetal weight coming down, and it is now going below the 5th percentile. And here the CPR, the most important for both, that has gone down. And I think this is the time when you should deliver. So these charts are very important.
Yeah, Dr. Vandana Mansal at 36 weeks, 2 days, CPR going down. What is your comment? 36 weeks, 2 days.
Significantly falling down trend. So I am also worried. The baby's growth also was going along that second, and then you see that growth of yours is showing a flattening. So I'm worried now. With this centile falling so much, I would probably deliver her.
Okay.
And she's a previous LSCS, I think.
Okay, I'm not going into this question as we have already. So now if at all you have to deliver this particular baby, they wanted to, I mean, they kept a kick count and all good, but then if at all you have to deliver at 37 weeks, what would you prefer? Induction, CS, Dr. Shell call. Can we have the obstetrician coming in? And yes.
Ma'am, actually, it would depend definitely initially on the Bishop score, because if with a very bad Bishop score, you're looking at a long priming and long observation process, which I don't think would be very advantageous at this particular point. If the Bishop score was very good, maybe I would leave it to the patient to understand, to have the choice of whether they want to go through intensive monitoring through labor or not, but still understanding that there is a high risk of fetal distress during labor, and it does affect. And I believe that most of the patients nowadays do not opt for a trial. They would prefer a cesarean section directly.
Okay.
I have yet to see any patient who
this
still wants to go for a trial of labor.
C-section also.
Can be in
The case of previous C-section, so it's
In
better
a
to go
previous
for
cesarean
serious
section, there is no point
Yes.
for induction.
So with such CPR, growth
Bella,
at
I still
Growth
think that we could induce her if it was not a previous LSCS.
Yes,
And
exactly. This
there is
was
a
a
higher
previous-
chance of distress, but we could induce them. We could. Let's not give that we should do section for all IUGI.
Definitely.
So this chart tells us very well Barcelona staging of fetal growth restriction for management. It tells us that this baby was in stage 1. So had it not been previous 1 C-section, as Dr. Vandana Bansal said, we could have induced and given a chance of vaginal delivery, and because the rest of the things were okay. And only if it is in stage 2, 3, 4 is when we directly go for C-section. But because in this particular case, it was a previous C-section with such CPR, we went for C-section and 1.9 kg baby was delivered by LSCS. So the learning points are very, very clear here that dating scan, the foundation of diagnosis of GR is very, very important. We see in 40% of patients, either the LMP is wrong, or when we look at the nuchal scan, it is not matching with the LMP that is given by the patient. So maybe if not anything, a good CRL at nuchal scan is something which every obstetrician must ask for, and the EDD which is decided then remains same. No further EDDs in next scans. That is one thing. And based on that, look at the centers. Ask for centile, ask for growth charts from your sonologist, and then we'll be able to diagnose and manage the fetal growth restriction better. And we have discussed about the rest of the points. So just quickly, what are the factors that you consider for timing of delivery in any patient? We have Dr. Shail call, so I would just we'll quickly go through this in any other case of fetal growth restriction. Apart from Doppler changes, what all you look at?
Yeah, gestational age and NICU facility, ma'am, and amniotic fluid and associated any maternal factors like preeclampsia and diabetes and
yes,
affordability also.
Very true. So in this particular case, it was there was no association of other maternal morbidity, but many early onset fetal growth restriction, 50% of them may have preeclampsia. And then we don't just look at the baby, we also look at the mothers, because if there's severe preeclampsia, that could be reason for triggering the delivery rather than just the Dopplers. So don't just look at the Dopplers, but then we have to look at the mother as well. Because I think we don't have much time. Quickly, I'll just go through the case too, because it's little interesting case. Komal, do we have time? 10 minutes? 5 minutes? Do we have Komal with us?
Nobody replied, so you can go ahead.
Ma'am, please continue. Please continue, ma'am.
Thank you so much. So this is an interesting case. 32 years, the non-consanguineous marriage, primary gravida, directly came to me at 19 weeks, 5 days. Patient was very sure of her dates, but short stature primary gravida. First trimester screening was not done. And when she came, she had a scan in hand and she was referred for a repeat scan and amniocentesis for high risk for trisomy 21 and neural tube defect on quad test. This was the quad test. So Dr. Samantha, can you tell us, when you look at any biochemical, whether it's dual marker, quad marker, what do you look at, first of all?
Yeah, we look at the markers, ma'am. Free beta HCG, alpha fetoprotein, and urinary estradiol, and whatever
You
are the
look
markers.
at the absolute values or
Absolute-
MOMs?
MOMs, ma'am.
MOMs, always.
MOMs.
Yes. So
Yes.
here, what does it suggest?
It shows it's babies at risk for Downs and neural tube defects because it's showing free beta HCG high and alpha fetoprotein is also high. And so, I mean, after, just not with this, maybe we have to interpret with again a scan. I mean, see for all the structural anomalies.
So
And then,
yes, you're very true.
yes.
So here
Yes.
the beta HCG in A are high. That's the reason, and the estradiol is on lower side. So that's the reason risk for trisomy 21 has come high. And alpha fetoprotein in Down should have been low. It's high. That's the reason they have put high risk for neural tube defect, right? You know that. So we always remember to look at the MOMs and interpret on our own also why this risk has come high for 21 and neural tube defect. Now, this is the report that the patient was carrying with her. Now, the radiologist look at the growth. If you can appreciate this, you can see all the centiles were less than 5th centile, whether it's BPD, HC, AC, FN, EFW. But the radiologist thought that this is wrong date and therefore the centiles are low. So it was actually 19 weeks, 2 days. But the report is showing single live intrauterine gestation 15 weeks, 3 days. He assumed that this is delayed conception and not fetal growth restriction. So is it true? How can we make out at just 19 weeks, 2 days, whether it is really delayed conception or fetal growth restriction and the centiles are really low? Anybody can tell you.
Ideally, we have a transcerebellar diameter, madam. It is the thing which can point towards the gestational age of the fetus.
Wonderful,
So,
wonderful.
if it is at 17 weeks and the TCD is really 17, then the baby is at 17 weeks of gestation and it can be an early onset IUGF.
So when we took as per the LMP, that 19 weeks, 2 days, the TCD was at 75th centile. That means the patient was sure of date. It was correct date.
Yeah.
And look at the growth. It was at 1 centile.
Yeah.
So it was a severe early onset fetal growth restriction. And we all know what could be the cause of early onset fetal growth restriction, right? So it was misdiagnosed as wrong dates, but actually it was an early onset fetal growth restriction. And then we would always look at the
anomalies also, madam. Other than the Dopplers, yes.
Yes, yes. Tell me. Yeah, Dr.
The structural, no, madam. Other than the Dopplers that you have shown, other than that, at 19 weeks, definitely the structural abnormalities, whether the baby has gotten any anomalies.
Wonderful.
Placenta, here you've shown, yes, ma'am. The placenta is also abnormal. It is showing placentomegaly, spaces are there, AVSD, heart abnormality, and single umbilical artery. Yes, ma'am.
Okay, so it's very, very obvious. There are so many markers there on the ultrasound. So important thing is so early fetal growth restriction, we always look at the structural malformations and any markers for aneuploidy or chromosomal abnormality, because it is very, very likely that baby is having some kind of genetic problem. So here there were markers which are telling us on face that this is likely to be a
genetically abnormal baby.
Abnormal fetus.
With some genetic cause, right? So now Based on the markers, Dr. Pikwesha, any comment, expert comment on this?
No, I think you picked up very beautifully. If you have only single soft marker like echogenic intracardiac focus, you would not have bothered much. But when you have two soft markers or one hard, then you have to definitely think in terms of some aneuploidy, and you have to go for chromosomal study.
Very true. Now, as practical, this thing we usually find in our practice, what could be the possible causes? Dr. Vandana Bansal, can you just elaborate in this particular case? Yes, we think of aneuploidy. Anything else?
So one is an aneuploidy because we saw all those markers, but that thick placenta with those vesicles that I see could be a kind of a partial mole. And if it is partial mole, we will see markers on the fetus also. And so severe IUGR so early in gestation with AFP high, with beta HCG high, it could be a partial mole also. So I will want that placenta to be tested and maybe amniocentesis here for microarray and fish.
Yes. So that's extremely important here. And why do we want to find out the cause? Because we know that
the recurrence
would be different, right? Yes, Dr. Vandana Bansal. On the recurrence, because aneuploidy, it has different recurrence. We know if it is partial mole, the follow-up will be extremely different.
Partial mole, one, we are worried about the recurrence also.
Yes.
Plus our monitoring for beta HCG will have to be followed up later on. And even the process of termination also will be little, has to be followed up and looked at X-rays and other things and monitored beta HCG.
So very true.
Aneuploidy, we will want to know what kind of aneuploidy it is, and depending on that, the recurrence.
The chance of recurrence.
So even if we are terminating, we still need to test.
Yes, that's what. So patient obviously with so many markers and severe early fetal growth restriction wanted termination. But what next? As madam has already discussed, best thing is to do amniocentesis so that we can have fresh cells on which we can do a microarray also, and we can store the DNA also for future any testing. And the other options, if the patient is not ready for that and wants termination, then we can do, anybody can comment on this. Any of the panelists.
Of autopsy for the baby, along with placental histopathology and DNA storage would make a lot of sense for this baby.
Yes. So in this particular case, yes, Dr. Pragna Mishra is not there. Otherwise, I wanted her because she's a lot into genetics. So we would want to send both placenta and fetal tissue. As Dr. Vandana mentioned, placental HP is also equally important because here we want to rule out whether there are any molar changes in that or not, right? And when you send for autopsy, can anybody, this is how the patient terminated the abortus, but the placenta was also sent for HP and there was DNA storage was done for this. Now, when you are sending a patient for autopsy, can anybody of any of the panelists tell us how to send the tissue for genetic testing and autopsy? Any one of you?
Right, madam. Like we do send it across in our center. So both are different. It's totally different. The moment you have the fetus expelled, the moment you have your placenta come out, you have to decide prior itself. You have to discuss with the parents what it is to be sent for. So for histopathology, for abortus, the fetus, the autopsy, you have to put it the whole placenta and the fetus as such into formalin. 10% formalin is definite, but prior to that, if at all they want a genetic analysis to be done, then you have to take a portion of, if it is around you have the fetus, it's bigger, you can actually take a part of the nail or even 1 into 1 centimeter of the skin of the fetus. Mainly we do take across the abdomen or the thigh and all, and that you should be putting it into saline with few drops of gentamicin. So only after you decide on that, you go into which to be sent for. Because once you put in formalin, it gets fixed. There is no going back. You can't go for a genetic analysis.
Wonderful, wonderful point. So that's very important. When the baby comes out, first thing you should keep a bottle with normal saline with few drops of antibiotic, gentamicin or any antibiotic, few drops you can keep. Take the tissue for genetic testing first. Right? As she said, 1 by 1 centimeter from maybe from the arm or from the medial side of the thigh, or you can take a tip of finger, or you can take 1 centimeter of the cord tissue also. All this has to be put in the sterile manner in that particular normal saline with antibiotic, and then the entire fetus goes into 10% formalin for autopsy. So these are two different things. Before putting in formalin, you have to take tissue, otherwise you'll not be able to do a DNA storage of that tissue. So that's a very, very important point for everybody to remember, that genetic testing and HP is different. So that was what was done in this. I think with this, a lot of messages have been given by our wonderful panelists. And any last comment by all the panelists? And I'm not going for the third case because we don't have time. We already run out of the time. Dr. P.K. Shah, we start from Dr. P.K. Shah and then other panelists.
Basically, I think we should do first trimester scan as far as possible for dating of any pregnancy. Forget about diagnosis of FGR. That is one thing. Secondly, when you have a suspect any case of growth restriction, please see to it that you chart it. You have charts, because the trend either of fetal growth or Doppler will give you immediate clue. Even if individual Doppler might be normal, it will give a clue that this baby is definitely going into growth restriction. And number 3, to avoid sudden deaths in third trimester, which might be because of late growth restriction, please do a third trimester ultrasound with color Doppler. I think this is going to work beautifully for all the obstetricians.
Yes, sir. My third case was about late onset fetal growth restriction, but I couldn't discuss that. So yes, as sir mentioned, it's extremely important for us to have at least a 32 and 36 weeks growth with Doppler, because that's when we'll be able to pick up some of the early onset fetal growth restriction and those who then at 36 weeks, late onset fetal growth restriction. And we'll be able to, we know that out of all 100% fetal growth restriction, only 30% are early onset, 70% are late onset fetal growth restriction, and they are responsible for 40% of late stillbirth. So if we do this 32 and 36 week scan with Doppler, we'll be able to prevent those 40% of late stillbirths. So yes, that was a very, very important point by our expert, Dr. P.K. Shah, sir. Yeah, we continue with Dr. Vandana Bansal, your message.
So between early and late, the doctors decides the time of delivery for a early FGR, and CPR and MCA decides for late FGR. So don't take that CPR for delivering at early weeks of gestation. There the umbilical artery high resistance and the ductus, which becomes reversal, will decide. And late onset, the CPR will decide. They don't wait for umbilical arteries to become abnormal. So our timing of delivery should depend on this stage-based management and on these Dopplers.
Thank you so much for that clarity, ma'am, because many times, because the CPR is abnormal, even at 30 weeks, obstetrician thinks of delivering the baby. So early onset fetal growth restriction, even if CPR is less than 5th centile, below 32 weeks, it just tells us that baby is able to cope up with the hypoxia. And you can still wait based on your ductus venosus and umbilical artery may be absent or reversal of diastolic flow in umbilical artery. So umbilical artery and ductus venosus are important for early onset fetal growth restriction. Whereas in late onset, once the CPR is below 5th centile, you have to monitor with kick count and your biophysical profile, your CTG, and take decision based on that. Thank you so much, Dr. Vandana Bansal. Yes, Dr. Suma, your message.
Yeah, yes, ma'am. Actually, once you diagnose a case as FGA or FGR, a multidisciplinary team approach is very important. Because once you land upon a case or once you tell the patient that you are going to have a small baby, you have to have a sit-down counseling with the patient and the couple, their parents, and along with the training obstetrician, the fetal medicine expert, if it is going in for an FGR, definitely with a neonatologist too. Because that proper counseling sessions can avoid so many problems. I think in a practicing obstetricians, right? So that a multidisciplinary that team approach will definitely give you a good way approach to FGRs.
Again, a very, very important point that the obstetrician, the sonologist, the fetal medicine expert, the neonatologist, geneticist, we all have to have sit together or maybe have online consultation together and take a decision, and the family, of course. So that only is going to help us.
They can prepare upon the time of delivery, the postpartum period, everything so they can be ready.
Thank you so much. Dr. Shyama.
Yes, ma'am. No, I just would like to emphasize on the point I think Vandana madam had told around even if we find a late onset FGR or we feel it is a late onset 32 weeks beyond you find, go back to our scans, do the scan yourself, see whether the patient, the baby has no other structural malformations, no other information related to the infection or the markers for aneuploidy, because always we tend to find it that, okay, it is a late onset. We just feel it's late onset. You don't see yourself, the anatomy of the fetus once again. And then that is when you have a trouble, like as you had mentioned about the duodenal atresia, even diaphragmatic hernias. There are so many late onset anomalies that you will find out at then. So that is a very important point. Look into the anatomy of the fetus once again. And also I would like to touch upon the corticosteroid and magnesium sulfate, madam, like the usage of that. I don't think that would have come in your third case, most probably. So yeah.
Yes, but that point I wanted to discuss, but because of paucity of time, we couldn't discuss. Thank you so much for raising that point. And yes, recheck and relook. Don't think that everything is normal. Every scan is an anomaly scan. You have to look at the structures and markers. Yes, Dr. Mansi Shukla.
So one small point I would like to make is that as radiologists and fetal medicine, the onus lies on us to give the image of our first dating scan. And because, the patient might go to her mother's place or whatever. So it should always be possible for them to check the dates, correct the dates if it is required. That was pointed out in one of your cases in which, that 15, 17 weeks becomes extremely important. And more than the 11 to 13.6 week scan, the 8 to 11 week scan, it is a better marker for dating, because at that time, the extension and flexion is never a problem, the neutral position. So that image should be given.
Wonderful. So that's also important. But only thing again for all of us to remember is if we are trying to rely on that 8 to 10 week scan, look at the image. If it's a proper good CRL taking, yes, it's a very good dating and we can rely on that. Or else 11 to 13 weeks. Yes.
11 to 13.
Point. Thank you so much. Yes, Dr. Samantha.
Yes, ma'am. Yes, ma'am. I would go with like multidisciplinary approach. Once we diagnose growth restriction, you should have a proper coordination with your fetal medicine head, and you as an obstetrician do your work, do counsel the parents accordingly, and also like tell them about the tertiary care level, and also like good NICU center is important. And I mean, you even coordinate with the neonatologist and say like the way it could be done, because it's our district place for us. So now, though we have a better facilities, but still a good scan report. Thankfully, we have very good radiologists and also like a higher center radiologist as like Dr. Chinmay there. So this is all multidisciplinary approach is very important. And also like timing of your corticosteroids and magnesium sulfate. If it's, early onset IUGR or late onset IUGR, go accordingly.
Thank you. Thank you so much. So if it's early onset fetal growth restriction and you feel Dopplers are bad and you are not able to, you don't have good NIC, you have to refer the baby in utero to a center.
To a tertiary care center.
Take care of you. So very, very important point. Thank you so much. And I think last message from Dr. Shell call. Dr. Shell.
Ma'am, I think everything has been explained in such detail. There's hardly anything left to discuss.
Yeah, thank you so much.
It's wonderful, ma'am.
So thank you so much. I think all of our panelists have discussed the topic so well, so that at least basic carry-home messages have been given. So thank you for being here for almost 45-50 minutes and discussing this and making it so interactive. Thank you, Dr. P.K. Shah sir, and everybody, all of you all, for being with. Yeah, hi, Komal.
Can I point out one more thing?
Yeah,
can I just make one more small point?
Please.
So these Dopplers, they are very good markers of hypoxia. But for acidosis, to check for acidosis, we need to rely on the BPP, the biophysical profile. That again becomes extremely important, especially in the late FGR, where the Dopplers are so fickle. So again, the role of BPP cannot be downgraded.
So that's what that was their discussion in third.
And role of CTG.
We couldn't
and role of CTG too.
Yes, CTG.
Komal, if you had allowed, we could have discussed third case and we would have discussed it at 8 o'clock. Hi, Komal. Are you there? I think she is. Hello. Can you hear us? Is she there?
Hello, dear ma'am. Thank you for such an interactive panel discussion. Your energy, enthusiasm is very infectious, Bela ma'am. And thank you all the experts, all the panelists for excellent inputs for this panel discussion. It is a topic of clinical dilemma, and Bela ma'am and all the panelists have successfully covered all the minutest details for the management. And definitely everyone in the audience, all the
we can discuss more.
Yes, everyone in the audience, all the obstetricians must have been benefited with the discussion today. Thank you all the chairpersons, all the speakers who have joined and made this webinar a huge success. Thank you everyone. I hand over now to Chitrakala. Are you here?
Yes, ma'am.
Who's there? Thank you, Anusha, and yeah, Anusha and Shruti, two MOCs for wonderful job.
Thank you so much, ma'am. It was an honor.
And thank you, Dr. P.K. Shah, for staying with us from beginning till end.
Thank you so much. Enjoyed. Very good moderator you are.
Thank you,
Hi,
sir.
Komal.
My pleasure.
Yes, sir. Thank you so much, Dr. P.K. Shah, sir.
Komal, we missed you in between.
I know. I just got disconnected, so I joined from phone. Yeah, but it was a fabulous panel. I really enjoyed everything, the messages, the how to go about. It was so beautifully discussed by every one of you, I can say. It was an excellent discussion. And sir, your inputs are really so valuable. We really look for your inputs and your guidance all the time. Thank you. I think it was an excellent discussion. And Anusha, you can give the vote of thanks.
Thank you everyone for joining and making this webinar a huge success, and looking forward to many such more webinars and your excellent inputs. Thank you everyone for joining today.
Thank you very much, all of you.
Thank you, everyone. Thank you.
Thank you.